Good afternoon, everyone. I'm Katherine Schubert, Deputy Director for Safety in the Division of Urology, Obstetrics, and Gynecology in the Center for Drug Evaluation and Research at the US FDA. Welcome back to day 2 of our public meeting, Scientific and Ethical Considerations for the Inclusion of Pregnant Women in Clinical Trials, which is being convened under a cooperative agreement between the FDA and the Duke-Margolis Center for Health Policy. We're thrilled that you all are able to join us again today, and we anticipate continued interesting, productive discussions. Today will look a lot like yesterday. We'll have a series of presentations, reactant panels, and moderated discussion sessions addressing the need for clinical research in pregnant people, as well as the scientific and ethical considerations for the inclusion of pregnant people in clinical trials. Today, we'll focus on approaches to clinical trial design and conduct, and next steps to advance therapeutic development. Before diving into the discussion, I would like to cover a few housekeeping reminders again. Next slide, please. The meeting materials are available on the Duke-Margolis event website. We also have Twitter information on the website, so participants should feel free to tweet about the meeting using the hashtag #ResearchInPregnancy. To our workshop speakers, Kaylee Probst is advancing the slides from the Duke-Margolis end today, so when you're ready for the next slide, please give a verbal prompt. Additionally, if you would take a moment now to update your participant Chiron with your affiliation, that would be a great help. If you're not able to do this, the Duke-Margolis team can take care of that. If you would like to speak during the open discussion portions of the meeting, either in your session or in other sessions, please turn on your camera and raise your virtual hand by clicking on Participants and then clicking on Raise Hand. Please keep yourself muted when you're not speaking. If you have a question or a comment during the open discussion or presentation portions of the meeting, feel free to type it into the Zoom chat box and address it to all panelists and attendees. To everyone, if you would like to ask a question or make a comment during the open discussion portions of the meeting, please type it into the Zoom Q&A box. I do want to note that we have some questions from the Q&A box yesterday, which we are going to revisit today. We again have a packed agenda, and to ensure that we wrap up on time, I would ask all speakers to keep their presentations within the allotted time limit, and for the panelists to keep their remarks to 5 minutes before each panel discussion. If you have technical issues, please send a direct Zoom message to Rashid Willis or email rwillis@newmediamail.com. There is live closed captioning available today. A recording of the meeting will be available on the Duke-Margolis event website and YouTube channel at the conclusion of the event. The Duke-Margolis Center is convening today's meeting in conjunction with the FDA. This is not a Federal Advisory Committee meeting, and while we value your input on this topic, we will not be following advisory committee meeting procedures or taking a vote at the end of the meeting. The workshop will be a success if there's a vigorous exchange of ideas and open discussion. A final housekeeping note, I would like to remind everyone that we aspire to use inclusive language in this meeting. I acknowledge that several federal documents, including the Federal Register Notice, the guidances and regulations which we may refer to, use the word women. FDA recognizes that sex and gender are distinct terms, with sex being defined as a biological construct and gender as a social construct. FDA understands that people self-identify by gender, and that for some people, sex and gender are concordant, while for others they may not be. Discussion of this topic falls outside of our discussion today. However, speakers and panelists aim to use inclusive language. Back to the workshop agenda. Next slide, please. So it's clear that we covered a lot of ground yesterday, and we really appreciated the presentations, contributions to the discussion, and insightful questions. I'd like to take a few minutes to summarize what we heard yesterday and what we hope to carry forward into today's discussion. Yesterday, we heard about the need to protect pregnant people through the increased generation of safety, efficacy, and dosing data for therapeutics used in pregnancy, as well as opportunities to learn from and scale studies that are successfully enrolling pregnant people to address gaps in knowledge about safety and efficacy for therapeutics for conditions that occur in pregnancy and for pregnancy-related conditions. We had a great discussion in session 2 on the utility and importance of non-clinical data collection for supporting clinical studies in pregnant people, including the utility of these data for risk characterization and dose finding. We finished the session with a discussion about FDA's expectations surrounding the quantity and type of non-clinical data needed to support regulatory decision-making, as well as pathways for conducting robust non-clinical studies for inclusion in IND submissions. We also spent a good amount of time discussing scientific and ethical considerations associated with trial design and conduct, including the impact of physiologic changes that occur throughout pregnancy and can affect drug pharmacokinetics, the importance of benefit risk determinations surrounding if and when to collect data in pregnant people, and opportunities to leverage existing real-world data and registry data where a lack of information on therapeutic safety and efficacy impedes access and could perhaps lead to adverse health outcomes resulting from an untreated maternal or fetal condition. Today, we revisit and dive deeper into many of these issues in our case study and next step sessions. In the first session today, our case study session, we'll spend some time discussing the impact of the therapeutic context, concepts like disease severity, disease burden, and drug characteristics, and the study objectives on trial design. Our second session will include a synthesis discussion of some of the challenges presented throughout the meeting, as well as a discussion of actionable next steps for increasing evidence generation, supporting access to safe and effective therapeutics, and improving health outcomes for pregnant people. I'll hand it over to our moderator for the day, Marta Woscinska from the Duke-Margolis Center for Health Policy. Marta?
Thank you so much, Katherine. My name is Marta Woscinska, and I am the Deputy Director for Policy and Consulting Professor at Duke-Margolis Center for Health Policy. And I will be moderating the next 2 sessions. Today's first session is entitled Case Study, Comparing and Contrasting Clinical Trials Enrolling Pregnant People to Evaluate Treatment for a Chronic Medical Condition and Clinical Trials for a Pregnancy-Related Condition. The presenters and panelists will discuss the impact of therapeutic context and study objectives on trial design for 2 different conditions impacting pregnant people. One is HIV and the other one is fetal growth restriction. That we will in today's session, we'll compare and contrast ethical and scientific challenges associated with trial conduct for studies enrolling pregnant people. We will begin our session with 2 presentations, one from Lynn Matheson, who is Senior HIV Technical Advisor for the Elizabeth Glaser Pediatric AIDS Foundation, and one from Katherine Schubert, who you have previously heard from, and who is the Deputy Director for Safety in the Division of Urology, Obstetrics, and Gynecology at FDA. After that, we will hear remarks from 4 panelists. Shaheen Lachman, who is Associate Professor at Brigham and Women's Hospital and the Harvard T.H. Chan School of Public Health. Then Susan Kindig, who is Senior Director of Pain, Neuroscience, and Internal Medicine at Eli Lilly and Company. Anne Lyerly, who is Professor, Department of Social Medicine and Associate Director for the Center for Bioethics at University of North Carolina in Chapel Hill. And last but not least, Yodit Bellu, who is the Associate Director for Therapeutics in the Division of Antivirals, the Office of Infectious Disease at the Center for Drug Evaluation and Research at the FDA. So first, I will turn it over to Lynn Matheson. Lynn, go ahead.
Hi, everyone. It's a pleasure to be here. Next slide, please. So I'm going to provide some background on potential new approaches and a framework on when and how to study antiretroviral drugs in pregnancy. Next slide. Excuse me. I don't have any financial disclosures. Next. So let's start with the usual situation for use of drugs in pregnancy. And we can use one picture to sum it up. I have no idea what I'm doing. The usual situation is that new drugs are already approved and marketed years before any studies in pregnant people are conducted, if any are conducted at all. Next, please. This slide shows the typical phases of clinical trial drug development. small phase 1 PK safety studies, larger phase 2 dose ranging and preliminary efficacy studies, phase 3 efficacy in the broader population, and phase 4 post-marketing studies. Next, please. And this slide shows the current timing of pregnancy studies, and basically none are done until the post-marketing phase 4, after which evaluations in pregnancy may or may not be done. Next, please. So currently, we first begin to study drugs in pregnancy post-drug approval. And in this situation, while dose, safety, and efficacy in non-pregnant persons, hopefully including women, is already established, there remains a lack of clarity about dose and optimal use in pregnancy. Next, please. So in the phase 4 setting, we first need to establish safe and effective dose in pregnancy. And the importance of doing these studies is illustrated by the elvitegravir and cobicistat studies in pregnancy conducted by P1026S and the PANA group, which enroll pregnant women who are already receiving an approved drug. And these studies surprisingly demonstrated significant subtherapeutic drug levels in pregnancy, as you can see on the graph. Next, please. Next, in phase 4, obtaining information about the safety of an approved drug in pregnancy is critical. And an example of this is the VESTED trial, which compared viral efficacy and safety between regimens that were already approved in non-pregnant individuals, showing superior viral efficacy of dolutegravir, and importantly, providing the first data on safety of TAF in pregnancy. Next slide. And then finally, there's the importance of phase 4 pharmacovigilance for rare adverse events such as birth defects. And the Tisambo model of birth surveillance was developed to evaluate the potential association of neural tube defects with preconception efavirenz. And it allowed us to definitively conclude there is a lack of association with efavirenz, but identified a potential small risk with preconception dolutegravir. Next, please. This slide shows the gap between FDA approval in pink to data in pregnancy for various antiretroviral drugs in green, with a median knowledge gap of 6 years after initial drug approval. And it's not necessarily getting any better, as several of the newer drugs have not been studied despite approval almost 3 years ago. Next, please. So our goal is to shift the knowledge gap for new ARV drugs in pregnancy so that pregnancy data are available at the time new drugs are approved in non-pregnant individuals. Next. And we can do that by moving up the time preclinical studies are conducted, conducting PK and safety studies in pregnant women during phase 2B or 3, and enabling enrollment of pregnant women in phase 3 trials. Next, please. So generally, conducting a first ever PK safety trial in pregnant women is warranted only if the preclinical data do not demonstrate severe adverse effects and dose and safety is sufficiently established in the non-pregnant population through phase 1, and that should be 2A data. Sometimes additional evidence on safety in non-pregnant individuals through phase 2B may be warranted before exposing large numbers of pregnant women. Next, please. So how do we get from where we are to a new framework, moving up pregnancy studies into the pre-marketing stage? And I'll discuss this in a little bit more detail. Next, please. Critically, the key to this framework is earlier conduct of the preclinical studies that are required before enrolling pregnant women, and which are often delayed until well after phase 3 trials have begun. Next, please. So questions related to preclinical studies include when in drug development should preclinical studies be done, and what issues need to be addressed to move this earlier? How should the preclinical data be interpreted? For example, when adverse findings with high animal doses are not seen with doses resulting in human therapeutic levels. And how to use these data to help decide when it's appropriate to permit women who become pregnant during a trial to stay on study drug, when it's appropriate to enroll pregnant women in a new trial of a new drug, and in which trimester, and finally, what kinds of later surveillance may be needed to capture outcomes of potential concern based on these preclinical data. Next, please. So while current trials enrolling women of childbearing potential require contraception for enrollment, it's really no surprise that such women become pregnant regardless of the trial's requirements. And so I just want to examine Partners' PrEP pre-exposure prophylaxis trial in HIV-negative women. Those intending pregnancy or who were pregnant or breastfeeding were excluded. Contraceptives were provided with monthly pregnancy testing, and if pregnant, study drugs were discontinued for the duration of pregnancy and breastfeeding. Next, please. And you can see 16% of women randomized became pregnant during the studies, almost 300 pregnancies. The study did do follow-up for pregnancy outcomes and importantly demonstrated no difference in outcomes between women on PrEP compared to those on placebo. Next, please. So questions related to non-pregnant women enrolled in trials who may be becoming pregnant include: what are the requirements for and choice of contraception? What needs to happen for the default position to be that a woman can stay on study drug if they become pregnant unless there are adverse preclinical data? And if allowing to stay on study drug, how can we incorporate PK and safety studies into the ongoing trial in order to maximize availability of pregnancy data? Next, please. So an example of a missed opportunity to gain pregnancy data comes from HPTN 084 trial, which compared long-acting carbotegravir with standard oral PrEP for HIV prevention in women, showing that carbotegravir was superior to tenofovir FTC for prevention. And this was great news for women, but only for those who were not pregnant, breastfeeding, or planning pregnancy. And the protocol noted that while preclinical studies were sufficient to allow women of reproductive potential to enroll, they would be required to use contraception, including during long-term follow-up. Next, please. And pregnant women or those desiring pregnancy were excluded, and participants were told to delay pregnancy for at least a year after stopping dosing. Next, please. And if they became pregnant, they had to discontinue drug. Next slide, please. So the preclinical data were actually relatively reassuring. The drug was not teratogenic in rats or rabbits. In rats, at 28 times the maximal human dose, there was a small increase in stillbirths and neonatal deaths, but no difference from controls at lower doses. Next. As one might expect, some women did get pregnant, and we do have some minimal data in pregnancy. There were 13 pregnancies during the study. 4 went to term with normal births. Most of the rest had elective abortion. And a PK study in 3 pregnant women after stopping carbotegravir was done, showing a rate of decline was similar to non-pregnant women. Next, please. So some questions. After approval, will pregnant women who are a high risk for HIV acquisition be excluded from receiving this drug because of limited data? Will women who become pregnant while receiving carbotegravir be told they have to stop drug because of limited data in pregnancy and breastfeeding? And could this have possibly been avoided by doing studies in pregnancy during the phase 3 study, which was, after all, focused on women? Next, please. So this raises questions related to enrolling pregnant women into trials and potential study design. How much and which safety and efficacy data are needed in non-pregnant adults prior to enrolling pregnant women? How do we prioritize drugs for study in pregnancy? Lack of alternative treatments, magnitude of potential health benefit for the woman or fetus, or the likelihood of widespread use of the agent in young women, such as carbotegravir for PrEP? What alternative trial designs would facilitate conducting such studies, and what pregnancy-related evaluations would be needed, and whether there should be interim pregnancy safety-related analyses with rules for early stopping for pregnancy subgroup? Next, please. So what potential study designs might be relevant? Next. So first, unless there are adverse preclinical information, in most cases, women who become pregnant on study should be allowed to stay on study drug, on study with consent. Next, please. Generally, PK studies in pregnancy would be delayed until after phase 1 and 2A studies are completed. However, for potentially life-threatening conditions for which there are no approved therapies, initial PK and safety studies could be considered during these phases, for example, for Ebola. And this would allow pregnant women to subsequently enroll into phase 2B and 3 studies. Next, please. We can consider the conduct of PK studies in pregnancy while phase 2B is enrolling in non-pregnant individuals, and then allow enrollment of these women directly into the phase 3 study. And since we wouldn't have extensive safety and efficacy data in non-pregnant persons, this might be restricted to studies in pregnant women, for example, who are failing current treatment, and the benefit of having a new drug is higher. And an adaptive approach could be taken where PK studies would first be done in late pregnancy, where there's theoretically less risk to the fetus, and then move to earlier third and second trimester. And this was the way it was done for the tenofovir microbicide trials. Next, please. Finally, one could conduct PK and safety studies in pregnancy at the same time. Phase 3 studies have begun in non-pregnant individuals, and this could be done as a separate PK study in pregnancy or as a sub-study to the enrolling phase 3 study with more intensive monitoring. And then following completion of the PK study with dosing for the drug, pregnant women could then be allowed to enroll into the ongoing phase 3 study to gather more evidence on the safety in pregnancy. Next, please. So to go back to our historical perspective of not knowing anything about pregnancy when a drug is approved. Next. We've learned as new drugs are developed for the treatment and prevention of HIV, studies in pregnant and breastfeeding people are critical and need to be conducted early, ideally before approval for promising drugs. Next. So let's have our update not be, I still have no idea what I'm doing. Next. But that we have data on PK safety and efficacy of new drugs in pregnancy at the time of new drug approval with the potential framework shown on the slide. And I think that's my last slide. Thank you very much.
Thank you so much, Lynn, for this great presentation. And now we will turn back to Katherine Sewell. Katherine?
Hi, so thank you so much, Martha. And thank you, Lynn, for your excellent illustration of studying drugs in HIV. Today, I'm going to present a clinical case study on fetal growth restriction to illuminate ways drug development for a pregnancy-related condition may differ from that for a medical condition that persists during pregnancy. Next slide, please. I do not have any financial disclosures to report. This presentation represents the views of the speaker and is not the official position of the FDA. Reference to any marketed products is for illustrative purposes only and does not constitute endorsement by the speaker or by the FDA. Next slide, please. So as many of you know, fetal growth restriction is a condition where a fetus is not growing as expected. The global prevalence is actually up to 10%. Fetal growth restriction is defined by the American College of Obstetrics and Gynecology as one where a fetus has an estimated fetal weight less than the 10th percentile for gestational age. And it's further defined by the Society for Maternal Fetal Medicine as either ultrasound estimated fetal weight or abdominal circumference as less than the 10th percentile. The diagnosis is usually made at an OB visit when the fundal height or the height of the uterus in the abdomen is measured to lower than expected and is usually followed by an ultrasound. And if the ultrasound confirms that the fetus is less than the 10th percentile for gestational age, then other studies can be done to assess how the fetus is doing by looking, say, at the amniotic fluid volume, and also looking at the flow of blood through the umbilical artery with Dopplers, and also looking at the fetal anatomy. So you can see already that there's not full consensus regarding the terminology or diagnostic criteria for fetal growth restriction. It's also notable that it's difficult sometimes to differentiate between a fetus that is constitutionally small and growing appropriately and a small fetus that's not fulfilling its growth potential because of an underlying pathologic condition. So just from the outset, we can see it might be a little bit hard to start designing a study for this condition. Next slide, please. So fetal growth restriction also has several etiologies. So the pregnant person may have a medical condition like pregestational diabetes or pregnancy-related hypertension, substance abuse. They may be carrying a multiple gestation. They could have been exposed to a medication or another substance that's teratogenic. They could have an infectious disease like malaria, rubella, or syphilis. The fetus itself could have a genetic disorder like a trisomy, where there's an extra chromosome, or a structural disorder like a congenital heart defect. Or there could be disorders with the placenta or the umbilical cord. So again, just setting the stage, because there's so many different etiologies, it could make it hard to determine what could be an appropriate therapeutic intervention to study for this condition. Next slide, please. So the next two slides are busy, and you don't need to look at all of the details, but I just wanted to point out, these are just some of the studies that are listed on clinicaltrials.gov looking at fetal growth restriction. And I want to point out that you can see for some studies, they're looking at drugs that are already approved for other indications, like aspirin, low molecular weight heparin, sildenafil, allopurinol. Next slide, please. Some studies are also looking at nutritional supplements like omega-3s, melatonin, or pomegranate juice. I also want to point out that most of the studies are randomized and blinded, but the control groups can vary between the studies. So some are looking at an active comparator, some are looking at placebo. Some studies are open label, some studies have no comparator. It's also notable that there are differences in the inclusion criteria for the studies. So some trials have different ages of the pregnant person. Some are enrolling pregnancies at different gestational ages. Some are looking at fetal growth restriction alone, and others add in other qualifiers, like they're also abnormal uterine artery Dopplers. And importantly, the studies are looking at all kinds of different outcomes. So some are looking at the mean birth weight, some are looking at estimated fetal weight, some are looking at the growth of the fetus through the remainder of the pregnancy. Most are looking at some neonatal outcomes like neonatal morbidity, neonatal mortality, and some are looking at neurodevelopmental outcomes in early childhood. So just shows that there's lots of different opportunities to look at different things when you're studying this condition. I did want to just talk briefly about the Dutch Strider trial. It's on the previous slide, but we don't need to go back to that slide. So the Strider trials were a large group of multinational studies looking at sildenafil. And it's an interesting case study because sildenafil has been used in the neonatal intensive care unit to treat persistent pulmonary hypertension in the newborn. And so the thinking became, well, if these babies were exposed to sildenafil while there were still fetuses in utero, maybe could they potentially have better outcomes when they're in the nursery? So the Strider trials were designed to look at the use of sildenafil in the antenatal period. And they were well-designed, well-funded, beautifully conducted. And at the interim analysis, there was evidence for futility and potential evidence for harm with an imbalance in persistent pulmonary hypertension in the intervention group. So the trials were eventually terminated, but I just want to highlight that you can design really nice trials for this not infrequently occurring condition and get unexpected results at your interim analysis, and then it's back to the drawing board. Next slide, please. So now I would like to just take a step back and look at the larger clinical context when it comes to fetal growth restriction. So at the FDA, some of the things that we consider are the nature of the disease. And one thing we look at is it a serious condition? And at the FDA, we define serious as whether the condition has a substantial impact on day-to-day function. And if you consider something like fetal growth restriction, for example, if that child has neurodevelopmental delay, that does have a serious impact on their day-to-day function. Next question we ask is it life-threatening? Well, yes, fetal growth restriction is potentially life-threatening to the fetus or the neonate. Other things we consider is there an unmet medical need? Well, I think we would all agree that in this situation, there is an unmet medical need. There are treatment options available, but there are no drugs that are approved for the indication of fetal growth restriction. There are therapies being used clinically and being studied, but in terms of the regulatory standard for evidence of substantial evidence of effectiveness and safety, we haven't met that standard yet. Next thing we think about is, well, when do we initiate the intervention in our study, and how long would a patient be exposed to this intervention? Well, that's also very variable. That depends on when fetal growth restriction arises. It depends on how the fetus is doing during the remainder of pregnancy, and are there other signs that develop that indicate that it's time to deliver the fetus? So those things both impact how long a fetus would be exposed. Are they starting in the second trimester, third trimester? How long is that patient pregnant while they're on the medication? And then another big thing to consider is the benefits. So do benefits of the intervention accrue to the pregnant person, to the fetus, or to both? Well, in a situation like fetal growth restriction, the benefits probably only accrue to the fetus. So we could prevent fetal death in utero, we could prevent preterm birth and its associated complications, we could prevent neurodevelopmental delay or deficiency, and early neonatal death. And remember, we talked about subpart B yesterday. So in a situation where the benefits only accrue to the fetus, we would need the consent of both parents. We also think about, well, could potential harm happen to the pregnant person, to the fetus, or both? Well, in this situation, it could be both. There could be a potential toxic effect of the drug on the fetus or the neonate, for example, persistent pulmonary hypertension in the newborn, or there could be fetal and neonatal death. And there could also be potential toxicity to the pregnant person. So we saw on previous slides that people are using aspirin or low molecular weight heparin. Well, those could cause bleeding in a pregnancy, maybe not so much during the antenatal period, but maybe at delivery. Or what about sildenafil? So say we enrolled a pregnant patient with preeclampsia and fetal growth restriction in the study of sildenafil, and then the patient developed headaches. Well, we wouldn't know if the headache is due to a worsening of the preeclampsia or if it's a side effect of the sildenafil. Next slide, please. So in terms of the drugs currently used for fetal growth restriction, let's talk about what we can leverage with the information that we have. So as I mentioned, there are no drugs that are approved for this indication, but we are using aspirin and low molecular weight heparin, either clinically or in studies. So in terms of these drugs, there is non-clinical data available on embryo-fetal development, pre- and postnatal development. There are pre- and post-market safety data in non-pregnant people, which could be used to support the safety in a pregnant person. There may be post-marketing data on use in pregnancy. The question is, if you have a pregnant person who is taking one of these drugs and continues it through the pregnancy, does the time frame during which she's taking it encompass the time frame that the drug would be used to treat fetal growth restriction? We could probably use some long-term outcome data on safety. The questions that remain would be dosing and efficacy. So the doses that are approved for non-pregnant uses haven't been evaluated in order to give us the regulatory standard for efficacy in a pregnant person. So we would still need dose information. And just by way of contrast, for a drug in development, one that's not been seen before in humans, we would need all of that same information as well as a proof of concept animal model. Next slide, please. So as you can see, the field is wide open. When it comes to a pregnancy-related condition like fetal growth restriction, there's a gap in information. So I just want to go through and say we were designing a hypothetical trial of an already approved drug that we're going to call normal growth for the new indication of the treatment of fetal growth restriction. Next slide. Okay, so normal growth is already approved. Let's think about the animal toxicology data that we have that we could use to support our study. So we'll have pharmacology, its mechanism of action, receptor binding, specificity, safety pharmacology. We have some pharmacokinetics. We have repeat dose animal studies that could potentially cover the intended duration of treatment and evaluate a dose range. We have toxicokinetics that could predict drug exposure in humans, inform a starting dose, help us calculate safety margins. We probably have, but may not already have, genotoxicity studies and reproductive and developmental studies, particularly fertility, early embryo-fetal development overall, and then pre and postnatal development. Next slide, please. So moving to humans, say we've got all of our animal data. If we have an approved drug like Normagrowth, what human data do we have that can inform our dose to study this in a pregnant person? Well, we have PK data, but we can't extrapolate that information because of the continuum of physiologic changes in pregnancy. So we would still need PK and pharmacodynamic data, and we could do preliminary safety studies in a small group of pregnant people. And here's where we begin to consider our risk of fetus. We would still need larger phase 2 and phase 3 efficacy and safety studies on the doses that we select. And that's basically the same as if it was a new drug in development. Next slide, please. So what about our study design? So we could do an open label single arm study of Normagrowth, but that's not likely to give us interpretable results. So it's best that we do a randomized blinded controlled clinical trial of Normagrowth plus the standard of care compared with placebo plus the standard of care alone. And our standard of care would be pregnancy surveillance. We would do ultrasounds, of course, looking at fetal growth. We'd also look at Dopplers, amniotic fluid volume, do fetal testing to assess fetal well-being. Who are we including in this study? Well, obviously, people who are carrying a pregnancy with fetal growth restriction. But how are we going to define it? Are we going to define it as estimated fetal weight less than 10th percentile for gestational age, or abdominal circumference less than 10th percentile? Are we looking at fetal growth restriction alone, or are we including other factors like abnormal uterine artery Dopplers? Are we including people with medical conditions like a hypertensive disorder? And these things can affect when we start the normal growth in pregnancy, right? So as we said, it can occur maybe in the second trimester or the third trimester. Are we going to start our drug when fetal growth restriction is first diagnosed, or when the fetuses develop other factors like abnormal Dopplers that make us think it's time to start it? And then, as we pointed out before, the duration of use of Normagrowth is going to vary. Maybe we continue until delivery. That's going to vary because there's uncertainty surrounding the optimal management and timing of delivery. We certainly don't want to wait till fetal death because we don't want any fetuses to die in our study. Next slide, please. Probably the most important thing that's going to impact our study design is the outcomes that we want to evaluate. So we could look at birth weight. We could look at fetal growth during the remainder of the pregnancy. Obviously, we'll be looking at Dopplers, amniotic fluid index. Obviously, we'll have fetal and neonatal outcomes like death or major neonatal morbidity. Maybe we'll include neurodevelopment outcomes in early childhood. You can see where this is going. This could end up being a really large and long study. And then we may consider having outcomes for the pregnant person in our study of Normagrowth. For example, if we included people with hypertensive disorders of pregnancy, will we look for the development of preeclampsia or HELP? So again, the field is wide open. Next slide, please. So we are going to hear from the panel and look at the discussion questions, but I just wanted to present that the clinical context and the study objectives really can impact the design of a trial for a pregnancy-related condition, and the physiologic changes throughout pregnancy and the physiologic changes that can occur with the condition itself do influence our outcomes that we look at. So thank you.
Thank you so much, Katherine, for this great presentation. So we will have now several panelists touch on a number of these discussion questions, and then we will come back to have a broader discussion that will also include questions from the Q&A. So if I could first turn to Shaheen Lachman from Harvard University. Shaheen?
Hi, can you hear me okay?
Yes, we can. Thank you.
Great. Good afternoon. It's truly an honor to share some brief remarks today related to a topic that's near to my heart, and I do not have any disclosures to report. I'm an adult infectious disease doctor and have been working since 1999 alongside colleagues in Botswana on HIV-related research there and in other low and middle income countries, and have co-led several randomized phase 4 HIV treatment trials during and after pregnancy, and hence was asked to comment today primarily on experiences and perspectives arising directly from this work. And so I kind of wanted to go through these one by one, and this is kind of more my personal experiences and some thoughts arising from those. So first, I have found that pregnant people appreciate being given the chance to decide whether to take part in research or not, and many individuals do indeed decide to join a research study. I wanted to actually share a few quotations from community members and advocates of persons living with HIV, all from African nations, as well as from a former participant in a pregnancy trial in Zimbabwe, and allow their quotations to speak for themselves in terms of research participation. The first one: share the information on what is known and not known about the risks of a drug and its side effects, what the clinical trial is all about, and that women can say no or can leave the study, all in the local language and in a way that is comprehensible. Give women the information that they need to decide whether to take part in the research or not. The second quote: during trials, participants have close monitoring. Why leave pregnant women to experiment with drugs but without adequate follow-up in the absence of trials? The third quote: research will provide the evidence that pregnant women need and may benefit the person who takes part in it. And finally, I was diagnosed with HIV during this pregnancy. I was shocked. The research nurse told me about the study. The team counseled me and followed me. They helped manage my antiretrovirals when I had virologic failure. It was very helpful to have answers to my questions. And as one example of the feasibility of research in pregnancy in low and middle income countries, we recently completed a randomized NIH impact network trial that Dr. Moffinson alluded to, the VESTA trial, assessing the safety and efficacy of 3 different treatment regimens started in pregnancy. This trial enrolled 643 women even faster than projected in 7 months, taking into account an enrollment pause related to external information. And IRBs in all 9 countries approved the research. So this is one example of many inside and outside the world of HIV, really demonstrating that people are interested in taking part in pregnancy trials and that they're feasible, including in low and middle income countries. I then next also wanted to just briefly share perspectives that I've heard from community members and trial participants regarding the contraceptive requirements that are usually instituted for taking part in clinical trials in non-pregnant people. I know this is not the focus of the meeting, but nonetheless relevant. So contraception requirement is obviously in many instances appropriate, for example, if there's concerning preclinical data or in early phase trials. But I have heard research volunteers express that the default requirement for use of contraception in order to participate in any interventional trial can be problematic. I again wanted to share some quotations from community members on the topic. The first: it is not fair that women need to be on contraception to be in a study. That is coercive and doesn't give me a chance to choose about taking part in research or about pregnancy. The second: women should also be allowed to stay on a drug and in a study if they become pregnant. Give me the facts and information and let me choose. And the third: let women make an informed choice. Tell them there is a risk if they get pregnant, but let them choose. Now kind of onto a more mundane, but I think a potentially impactful topic in terms of planning pregnancy trials. And this really emanates from my experience, but dovetails perfectly with Dr. Moffinson's comments. So we all know that the time from initial conception of a study idea to the initiation of enrollment to an interventional trial often takes many years. And if we are to shorten this timeline and make this process more efficient, it would behoove us, I think, to consider several approaches. The first couple have been mentioned by Dr. Moffinson. If possible, complete preclinical studies earlier in drug development and permit people who become pregnant in a phase 2 or 3 trial to consent to stay on drug unless there's a specific concern not to, and collect PK and safety data. Then for promising new drugs that have potential for substantial benefit over current standard of care that may be used widely by people who become pregnant or young women, and for which a pregnancy study may be warranted, start planning for that pregnancy trial early. For example, during phase 2. And either plan to start a separate pregnancy trial as phase 3 winds down or shortly after drug approval, or perhaps in parallel with phase 3 trials in non-pregnant people. Then ideally maybe write protocols in such a way that you can include starting rules that may be based on data that may still be forthcoming. So for example, if when you're writing the trial protocol, pregnancy data are expected from another study but not yet available, starting rules based on those forthcoming data can be incorporated to shorten all of the regulatory reviews and timelines. And then consider protocols that include a seamless or stepwise approach. Again, Dr. Moffinson mentioned this. So for example, start enrollment in late 3rd trimester with external safety monitoring. Then should that prove to be reassuring, move enrollment back to the 2nd trimester sequentially, enrolling earlier in pregnancy, depending on safety results. And Dr. Hillier is doing a dapivirine vaginal pre-exposure prophylaxis trial using this, and it seems to be working well. And then consider adaptive or platform designs where you enroll pregnant women in sequential designs of new agents, compared, for example, to a contemporaneous control. And all of these steps could, they're again mundane, but could really shorten the time to availability of robust pregnancy data. And then I wanted to end my remarks with some thoughts on just kind of a miscellaneous group of thoughts based on my hard-won experience. So for HIV and chronic medical conditions like HIV, I think much of the initial focus is on the disease endpoints and outcomes, and not necessarily on the pregnancy outcomes. So for HIV, that was on preventing initially vertical transmission, but it's become very clear that we need to pay close attention to pregnancy outcomes. And in more than one instance, antiretrovirals that were recommended as preferred agents in pregnancy for many years were ultimately actually found to be associated with worse pregnancy outcomes after rigorous study. And in contrast to HIV endpoints like virologic suppression or vertical transmission prevention, adverse pregnancy outcomes can really, as you all know better than I, differ substantially by location, population, measurement approach, and even time of year. And so any comparison of adverse pregnancy outcomes between groups needs to, of course, be done with great care, and for some very important drugs, potentially in the context of a randomized trial. And these pregnancy outcomes should really be considered a key important endpoint of trials for new HIV prevention or treatment that may be used in pregnancy. Then I just wanted to give a shout out to Dr. Little and her amazing talk yesterday and kind of echo her feeling that prospective population-based surveillance for pregnancy and other outcomes would be incredibly helpful for generating a more robust understanding of post-marketing drug exposure and the impact on rare outcomes or first trimester drug exposure. And the Tsepamo study that Dr. Moffinson mentioned from Botswana has now systematically abstracted outcomes and exposure data for 180,000 pregnancies in Botswana, which led to some important insights and is not subject to some of the huge challenges with registries without representative sampling and denominators. So prospective surveillance. Then I think if you design protocols carefully, you can reduce unwarranted consternation that can happen when rare events like congenital anomalies occur. So in many low and middle income countries, and most, women do not have a routine antenatal fetal ultrasound. But if enrolling women in pregnancy, ideally that will be done prior to enrollment, both for dating purposes, but also potentially to not enroll women who have a fetus with a known anomaly, which could inadvertently be ascribed to a treatment intervention, if not excluded from enrollment. And then obviously we need a very thoughtful communications strategy involving stakeholders, including community throughout, and a framework for prioritizing agents for pregnancy trials. And a World Health Organization impact collaboration is actually systematically evaluating all of these possibilities in a series of ongoing workshops and meetings related to HIV and pregnancy studies, and aims to create a toolkit that will help facilitate all of this work later this year. So I think in sum, my experience has taught me that pregnant people appreciate being offered the opportunity to take part in relevant research, and that research is feasible. With foresight and planning, we can take multiple steps to shorten the timeline and improve the efficiency for conducting these trials. And these trials could provide information to pregnant people and their providers needed to help make informed decisions about their care. Thanks, that's it.
Thank you so much, Shaheen. So if we could now turn to Susan Kindig.
Hi, everyone, and I don't have any slides as well. And just for disclosure, I do work at Eli Lilly. So the views, though, for today are of my own and not of the company that I work for. So just for a little background on why I'm interested in this, I am an OB-GYN by training and practice for several years prior to joining Lilly. And I've worked in their safety department now for the last 9 years. So I want to give you today just a little bit of a peek into what the industry approach is to safety and pharmacovigilance, and help you all understand why those of us are on the call today are so interested in including women or including pregnant people in clinical trials. So the goal of safety physicians and scientists really is to be able to communicate appropriately the risks of our drugs. And to do that, we clearly have to be able to identify the adverse events that are really related to our drug, and then be able to determine which of those needs to be put in clinical labels and warned then appropriately through warnings and precautions. So to do so, for all drugs, we start off with our phase 3 trials, as people have described already, and we're looking very closely at all of the adverse events that get reported in clinical trials, and comparing those adverse events on drug to any adverse events on either a placebo or on other standard of care. And we're looking at that along with medical judgment as to whether those adverse events really are causally related to our drug. So we need that we need that phase 3 and oftentimes phase 2 safety data to be able to make that initial determination of what are the adverse events that are clinically related to our drug. And clearly that happens differently for different populations. So in the pregnant population, we need that comparison as well. Otherwise, we won't be able to determine postpartum hemorrhage, preterm labor, things like that. We're not going to be able to look at those appropriately unless we have that comparison data. So then once drugs are approved and into the masses, that is when we can use post-marketing data to, especially in those first couple of years after a drug is on the market, that is when our safety physicians and scientists need to be hypervigilant and look for any signals for new adverse events that weren't determined in the phase 3 studies, because we just didn't have enough patients being exposed, and be able to determine those adverse events that happen at a lower rate in the community. So that post-marketing data is extremely important to us, but unfortunately, it's got a lot of limitations, unfortunately. And limitations for the first post-marketing data would be spontaneous reports. That is what we get most often in the post-marketing setting. And unfortunately, I had no clue about this before I got into safety, but the post-marketing or the spontaneous reports can be extremely limited in their data. We get sometimes reports that say a 56-year-old white male took a drug and then was found deceased in his living room. That may be the only bit of information that we get, clearly not enough for us to help determine whether that could be a causal relation to a drug that he was taking. And clearly we get other adverse events that can have more data, but it's still very limited despite how much effort we put into going back and trying to get information about that. Limitations of spontaneous data also are that they're frequently underreported, and we lack a denominator in to be able to use that then appropriately. Other sources of information, then obviously pregnancy registries, which we're all very familiar with. We know then that the pregnancy registries, some are quite good and do a great job with enrolling. Others, despite best efforts, we still have a lot of enrollment issues and can spend many, many years only collecting maybe a handful of cases, maybe 30, 40, 50 cases after 4, 5, 7, 10 years, which really doesn't give us enough information, obviously. One thing that we've used in the past several years now are the large database studies, which can be very helpful to give us an idea as to those adverse events that happen less frequently, such as the major congenital malformations. Unfortunately, once again, we're burdened by understanding the more rare adverse events. We can hopefully find major congenital malformations overall in a database study, but it's going to be a lot harder unless we have lots and lots of patients, as Shaheen was talking about, which would be a wonderful database to look at to be able to find those more rare adverse events. So that's more how we look at things. We clearly need that randomized prospective clinical trial data to be able to help us evaluate pregnant patients appropriately. And I'm looking forward to helping with the rest of the panel to answer some questions coming up. Thanks for your time.
Thank you so much, Susan. So if we could now turn to, for some remarks to Anne Lyerly.
Thank you very much. My name is Annie Lyerly, and like those before me, I'm truly delighted and honored to be here. As a reminder, I'm a professor in the Department of Social Medicine at UNC and the Center for Bioethics. I practiced OBGYN for several years, but now have fully turned my focus to ethical issues in reproductive medicine and have devoted a lot of my time in the last 10, 15 years to thinking about the ethics of including pregnant women, pregnant people in biomedical research. And want to just highlight again, as Maggie Little did yesterday, the Prevent and Phases projects and their published guidance for research with pregnant people, mostly in infectious disease context, though there are ethical frameworks embedded in there that I think are useful to research with pregnant people generally. I also want to tip my hat to FDA's leadership in this critical area. So obviously I was asked to talk about some of the ethical issues that wonderful presentations raised. So I want to first start by saying that, you know, despite the tremendous progress we are seeing on this topic, the paradigm shift that highlights protection through research, we are still up against a long history of what I'll call misprotection of pregnant people that has historically led to their widespread exclusion from research. So in reflecting on the two presentations, I'd like to point out some vestiges of misprotection, if you will, that are still important to recognize and address. So the first is the requirement for paternal consent. Dr. Sewell correctly noted in her talk that in a study that holds the prospect of direct benefit for the fetus only, the consent of the pregnant person and the father is required according to subpart B of the US federal regulations. So I just want to note that this is a rare, maybe singular instance in research ethics where the consent of an autonomous adult is not sufficient for that adult's participation in research. The requirement has actually been long contested, highlighted as a barrier to research, especially in the HIV context in the 1990s, almost eliminated when subpart B was revised in 2000 and maintained in this one circumstance where there is only the prospect of direct benefit to the fetus, because as you might imagine, it was easy to argue against veto power for a father that would preclude a woman to participate in a research study that was of benefit to her. So arguments against paternal consent include it fails to respect autonomy, it fails to attend to the complexities of relationships, it is inconsistent actually with international guidelines like SIOMS, and finally, it is more restrictive than what is required for born children. In research that carries the prospect of direct benefit to a child that is outside the body, the consent of one parent is sufficient. But when the child or baby or fetus is inside the body, you need the consent of two individuals. PREGLAC, it was mentioned yesterday, has recommended that this requirement be removed, but of course it can take years and a lot of debate for federal guidelines to be revised. So another approach is to recognize just actually how unlikely it is that an intervention has the prospect of benefiting the fetus and not its mother. Their physiologies are entwined and so are their interests. So is it possible when we're thinking about studies to hypothesize and then measure the ways in which an intervention that prevents fetal growth restriction, for instance, might benefit the pregnant person as well during pregnancy or after, right? We know that fetal growth restriction is related to maternal health, so preventing it might involve improvements to maternal health as well. So, which leads to the second vestige of misprotection, which is the vessels and vectors problem. So there's a history, especially in the context of HIV, of not giving fair consideration to the health outcomes of pregnant people, particularly in studies aimed at fetal disease. Again, Shaheen talked about our failure to study the maternal health impacts of antiretrovirals and the need to do that more in future studies. Another example is in utero surgery, once called fetal surgery, until it was emphasized that surgery on a fetus requires surgery on somebody else as well. Thus, the term maternal fetal surgery was adopted by some. Attending to the vessels and vectors problem might help sidestep the requirement for paternal consent, but it also gives due respect to women and fosters relevant outcome data for pregnant people. Excuse my use of the term women. I've been in this field for so long, it just flows out of my mouth. The third vestige is what I call risk shifting. The idea is that when you don't include pregnant people in research, the risks do not go away. They just shift to the clinical setting where they grow. They grow, as Lynn pointed out, because when people who are pregnant take cobicistat, and it takes years to figure out that the normal doses aren't adequate, those people who took cobicistat in the interim are exposed to resistance and vertical transmission risks. There are 100 other examples. The fourth vestige is the treatment prevention disjunct. As others have noted, we do research with pregnant people in certain contexts where the need seems obvious and high. HIV is a great example. Early in the epidemic, there was such a strong appreciation of the risks of perinatal transmission and the need to do research to accomplish it effectively that it got done. But it didn't translation rate to the prevention setting where pregnant people are usually excluded. Even though you get pregnant and you get HIV the same way. Note a full 16% of the people who participated in the Partners PrEP study got pregnant, advised as they were not to. Moreover, the risks of perinatal transmission where maternal infection occurs during pregnancy are higher. For both of these reasons, prevention is one of those cases where inclusion is not just permissible, but rather it's an ethical responsibility. I have one more point to make, and then I will pass it along to my, my co-panelist. The fifth example of misprotection is reticence. It's one of the less well-recognized harms of not studying medications in pregnancy. Without data, access to many drugs is limited. There is a question about whether pregnant people will ever get fair access to a highly effective injectable preventive cabotegravir, not because it's unsafe, not because it doesn't work, but because we didn't have the will or the authority to study it in them when it was appropriate. And we're seeing the same situation roll out with some of the COVID vaccines. So pregnant people deserve better, and I'm so delighted we're here to talk about how to make that happen. Thanks very much.
Thank you so much, Annie. This was very helpful. And next, I would like to turn to Yodi Bellew.
Good afternoon. Let me just make sure my video is on. Can you see me?
We can see you.
Okay, great. Hi, everybody. Good afternoon. Thank you again, Lynn and Katherine, for that excellent presentation. By way of background, again, my name is Yodi Bellew. I'm from the Division of Antivirals in FDA, and my training is in pediatrics and pediatric infectious diseases. So I will share a couple of points from just my experience working in the division and managing or helping with clinical trial designs for evaluating antiviral products in and pregnant women. So the first point that I wanted to make is related to population. So as Lynn kind of alluded earlier, we can think about population where individuals who are not yet pregnant but are enrolled in a clinical trial, and then during the trial they become pregnant. The other population is individuals who are already pregnant but enrolling them into a clinical trial. So I think the benefit risk considerations are different for these two populations. With respect to the former, I think the work needs to be done early on during the protocol review and the protocol writing to make sure that we think about, do we have sufficient non-clinical data to allow women who become pregnant, or individuals, pardon me, who become pregnant to continue on the clinical trial. Also to think about reconsenting and making sure that the individuals are fully informed of the benefit risk if they choose to continue in the clinical trial. With respect to enrolling pregnant women into clinical trials, I think we have to think about slightly different considerations here because they're not already exposed to the investigational product like the former scenario. In the former, one could potentially consider that, you know, the individual who's already receiving the therapeutic, the investigational therapeutic, might be directly benefiting from it. And in the case of treating HIV, we can look at, for example, viral load to determine that the individual is gaining benefit from the investigational product. Whereas when we're looking at enrollment of individuals who are already pregnant, we have to think about what is the added benefit in enrolling into this investigational therapeutic. We could consider, for example, scenarios where, to go back to the HIV paradigm, if the individual, the pregnant individual, is failing her current regimen and is not fully suppressed, there's a risk not only to her health, but also potentially transmitting the virus to the fetus or the infant. And so in that scenario, one could justify enrolling those types of individuals into an investigational product, into a phase 3 clinical trial, for example. So just highlighting the different benefit risk for considerations for potentially different populations. The second point I wanted to highlight relates to, and this was already alluded earlier and yesterday as well. Again, I want to reaffirm that FDA is committed in advancing the sciences and ensuring that pregnant individuals are represented and included in research, that they're being protected, not from research, but through research. We have to think about what kind of clinical trials we're talking about. So in disease settings such as HIV, where the primary focus in these pre-market studies is looking at PK/PD markers because we can extrapolate the efficacy, the goal of the study is really to collect PK and some PD markers, and then comparing the PK in pregnant individuals or the exposure in pregnant individuals to those non-pregnant adults, and targeting a dose where the exposure in pregnant individuals or pregnant population is similar to the non-pregnant population. So when you have that kind of a PK-focused clinical trial, your safety data is going to be quite limited. We're talking about handful, 30, 50 individuals. And so we really have to think about the value of post-marketing studies, be it through a dedicated observational prospective trials like previously mentioned, the Sampamo study, which was a fantastic study, or relying on established registries such as the APR or the antiretroviral pregnancy registry. And I think having that larger database to kind of supplement the small safety data that we've collected through clinical trials in the pre-market setting is very valuable. So thank you again for your attention, and back to you, Martha.
Thank you so much, Yodit. So we can now turn to a broader discussion with the full group of panelists and the speakers. So if I could ask Yodit, Annie, Shaheen, and Lynn, and Katherine, and Susan, yes, if you could come back on video, that would be great. So here again are the discussion questions that were laid out for this session. And we have actually been discussing all three throughout this session. These are high-level questions. And if you look at the Q&A session, there are a lot of sort of deeper dive questions that kind of go into this. And so perhaps what I could do is ask a couple of more specific questions, these deeper dive, and then also invite the panelists and the presenters to add other aspects that might relate. So I just wanted to take a step back and say, you know, Lynn's presentation included some very interesting data about when studies involving women, pregnant people actually occur, and that there's this really large gap, and we're trying to shift it back to as soon as the drug is basically approved and what it would take. But we're also spend the entire session discussing about how to do this, you have to really understand the clinical context, the therapeutic context for the disease, and that's going to drive of what these trials are going to look like. So I wanted to ask a couple of sort of follow-up on the clinical context. So for example, a couple of questions that came up in the chat were around, here's one. What if the benefit only applied to the mother and the fetus? How would this change how this calculus is applied, not only in terms of timing, but also in terms of the design of the clinical trials? If any of the panelists or speakers would like to comment on that. And maybe we could take down the discussion questions, so then we could then see all of our panelists on one screen, because I think we don't fit on it together. If we could go to the gallery view, that would be best. Thank you.
Well, I mean, I can start just by maybe critiquing the notion and just reminding everyone about the intertwinement of maternal and fetal physiology. So one of the things that is often not remembered is that maternal health is a predictor of fetal and neonatal health. So, it tends to be the fact that if you're treating a maternal disease, that is going to have a health impact on the fetus. And so the important thing is to measure that, right? To look at what the outcomes might be without it being treated and the outcomes with it being treated. And we have lots of examples of the ways in which maternal and fetal health are interlinked. And I also want to make the point, although, you know, we don't, you know, there is this question about how it relates to the legal situation, but as, you know, people who study the impact of things on fetuses have noted, I mean, drugs are one category of teratogen, right? But other categories of teratogen are the environment and infectious diseases that may have an impact on the mother, but they also can have an impact on the fetus. So I think it's very hard to tease apart, and even probably not correct to hypothesize that benefit accrues to only one but not the other, or risk.
Would anyone else like to comment on this?
I agree.
As do I.
Excellent. So another question along the lines of the context is, Katherine, you discussed the fetal growth drug. What if that drug had not been previously approved? How would this change how we would think about it? It only applies to pregnant people, obviously. How would this change how we think about the design of these trials?
Yeah, so that's a great question, and I'm happy for other people to chime in as well. I think the way that I was thinking of it is that actually it doesn't make that much of a difference, because the gaps in knowledge for drugs that are approved already in pregnancy are so large that it's not that much different, I think, from a drug that has not yet been seen. I think really in terms of the therapeutic context, it's going to be, you know, really based on the seriousness of the condition, right? Like how much of a risk is it to the fetus? What risks the pregnant person might be at as well. Otherwise, I don't see that much of a difference. I don't know if others have thoughts.
So I'm happy to jump in here if you don't mind. So this is something actually that we've talked about in PregLac. We need to have a cultural change. We need to have that shift so that we can start thinking about, it's the only way we're ever going to be able to think about drug use in problems that happen just for pregnant people. So we're going to have to start pointing out that women are, half of the population, and it's how every single person in this world came into being. So it behooves us all to help improve that situation, but it does need to be a huge cultural shift. It is something that we're going to have to talk about the medical legal ramifications of it. How are we going to address liability? Because that is a common problem it's a common concern that physicians have. It's a common concern that drug companies have. We're all worried about liability, especially here in the United States, where the legal ramifications are, I think, a lot greater than in other countries. But it's something that we absolutely have to start addressing. And so that is something that we've talked about in PregLac quite a bit and will be an ongoing discussion.
So let me ask another question that came up in the discussion that actually relates, I believe, to our question number 2. In terms of, so this was specifically directed to you, Katherine, but I would welcome input from others as well. Would you start in pregnant people in third trimester first, assuming safest period for developmental effects, and then staggered enrollment to second trimester using information from third trimester, such as PK and safety?
I think that that's a reasonable consideration, but again, I think it really depends on the clinical context of the disease, right? Drugs can certainly cause some issues in the third trimester as well. It's not as though the fetus is not at risk in the third trimester. I don't know what others want to add to that.
Hey, I think that it's a reasonable proposition, but I think one of the challenges with that is that some of the some of the concerns that you might have with second versus third trimester exposure, you might not be able to pick up until much later, whether it's child neurodevelopment or something like that. So functionally, if you're really going to take that to its logical conclusion, you might need to, enroll women in the third trimester, study them 5 years, the children 5 years later, and then go back and study it in the second trimester. And that's obviously not practical. But there may be situations in which it makes sense if it's to me, I'm just thinking, if it's a very new class of drug that hasn't been used much in pregnancy, and if you're concerned, for example, about, for whatever reason, about pregnancy outcomes, where you would be able to evaluate that with external safety monitoring in near real time.
Of course, that doesn't necessarily help you with dosing throughout pregnancy, because it's the second and third trimester where you have physiologic changes that result in dose differentiation. So it as I think Katherine was saying, it really depends on what you're studying.
And I think too, we also have to be careful that we are studying it early enough in pregnancy for it to have an efficacious benefit. So if we start testing too late in pregnancy, the damage may already be done, and we may not be able to get that good effect. If we start in the second trimester, we might be more likely to have a good outcome. So pros and cons for both.
So it all depends, is the answer. So one other question that is related to actually PK levels is, on individual versus PK population level PK. Dr. Sewell mentioned that we can't extrapolate PK data because of the continuum of physiological changes during pregnancy. So it's a very related question. Would PB, PK modeling and bridging from non-pregnant PK studies help increase the efficiency of the PK studies in pregnant people?
I think they've started to do that in HIV with antiretrovirals, and I think it's been very useful.
And I think this is definitely an approach that we've been considering. Again, there are other factors that we have to think about like the structure of the molecule, you know, crosses the placenta. As Shaheen Lachman was saying, what are the long-term effects? Are they functional? So still lots of things to consider in terms of that as well.
But you can do some studies to help address that. For example, there have been some really interesting studies now suggesting that cabotegravir does not cross the placenta like other integrase inhibitors do. And if that's true, then all of the concerns about teratogenicity that were the holdup don't really hold, do they? So doing those kind of in vitro studies and those modeling studies, I think, are very helpful to push things forward. But they have to be done early. They have to be done while the clinical development is underway to be able to get to the point where you would enroll the pregnant woman into that, say, phase 3 study.
One other thing that I would like to say, just in terms of the PBPK modeling, is that I think even to develop the model, we need some exposure data in pregnancy in the first place, right, in order to build a model.
So actually following on this question, because we're talking about a modeling approach, there's a question that actually, Lynn, you raised in your presentation, which is what alternative trial designs would facilitate safety, speed, and efficiency? Are there other ways through which we could improve safety, speed, and efficiency, and through alternative trial designs that you would basically recommend looking at as?
Yeah, I think the easiest is the two things that I was talking about for phase 3. So first is, as you go into a phase 3 trial, conduct that safety and PK study separately to then allow the pregnant woman to enroll into the phase 3 trial. If you wanted to do it more rapidly, you could do it as a sub-study of the phase 3 trial. But that involves a lot of modifications in phase 3 studies that perhaps companies and investigators don't want to deal with. But that, I think, would be one way to make it more efficient. Maybe Shaheen might comment on that.
I agree, and also just wanted to kind of share an idea that people have been discussing that is not yet realized in the HIV world, but is that, you know, to avoid the inevitable delays and expansion and contraction of really expert clinical research staff and to enhance efficiency, it may make sense to consider for something like HIV, where you kind of have sequential introduction of new and better drugs, for example, long-acting treatment and prevention agents and monoclonal antibodies, and, you know, these new modalities for treatment and prevention, to consider a platform trial that continuously enrolls, you know, a control arm that's an active control. We're well beyond placebos, you know, for treatment and prevention of HIV, of course, but an active control arm that's contemporaneous with introduction of a new antiretroviral. And that is just something that people are considering. And again, as I kind of, anything that can be done, some of these details and the delays are completely boring and mundane, but they have to do with protocol modifications and letters of amendment and a new protocol and getting it approved by 8 different, you know, groups that need to. And so to the extent that you can specify in a protocol how you will use new data that are coming from other sources, whether it's PK data to help you decide when to start your study, or transition from one phase to a study to another without requiring a separate protocol or a new letter of amendment, that also really helps speed things up.
Yeah, Shaheen, I would echo that. I think having a master protocol will save a lot of writing new protocols, writing new, you know, designs, etc. So having one master protocol where you could essentially use it as a platform to run multiple newer investigational products would definitely save some time.
Well, we've already done that, but it's all phase 4, right? So P1026S takes women who are already on drugs and then does PK in them, which is great. And Shaheen's Vested was a terrific example of it. You could take that and keep it rolling. But that doesn't address the issue of bringing it back to getting that information at the time the drug is developed. So you need models to have the rolling protocol, in quotes, for those types of situations. And that's a more difficult design.
Susan, would you like to chime in here from your perspective? How do you think about what could be some alternative designs, trial designs, and methodologies that you have been thinking about that could be applied here?
Yeah, I will tell you, I don't have a whole lot to add from that because we have not been, there are so few studies that have enrolled pregnant women, at least in my experience, that I've gotten to be involved with, and haven't really even been involved, but it's more the COVID trials and the monoclonal antibodies that I know one difficulty is getting them through the IRBs. And so it's difficult. Once again, it's going to go back to that cultural shift, and we're going to have to get buy-in from so many different groups in the world to be able to speed these things through. Because if all of a sudden we now have an IRB that says, nope, you can't do that, then you're going to have to go back and spend several more months. So it really is, I think, setting up the processes ahead of time as well, and making sure that we have the buy-in from all groups.
So there was actually a question in the Q&A that related to this. What additional expertise should be sought when determining to include or allow pregnant women to continue? This is actually for continuing in a, this is for continuing in a clinical trial rather than even thinking about enrolling it. So who do you bring to the table to be thinking about these IRB issues? Is it the FDA, independent ethicists, maternal medicine specialists, teratologists? Could you speak to that? How do you overcome, I guess, on both fronts? One is when we're thinking about designing a trial and including pregnant people, and then also how do we think about those that might become pregnant, and how do we think about incorporating them? Who needs to be at the table for this to happen?
I can share our experience for antiretroviral trial designs. I mean, certainly it's a multidisciplinary consideration, not just the division, but sometimes we also include our ethicists within FDA as well as the Division of Maternal Health. But essentially, I think the key is to start the conversation at the protocol stage and not wait until somebody gets pregnant in the clinical trial and then you're trying to figure out what to do, discontinue or not. So that, to me, the planning is the key. And at the time of the protocol submission or writing the protocol, we have to think about where we are in terms of the non-clinical data. What do we know about the class? You know, to ensure that the investigators will allow for unblinding, reconsenting, discussing benefit risk, and also to kind of look at, you know, the individual at the time that the pregnancy happens. Is the person gaining benefit from continuing in that clinical trial? So those are the key points for consideration, in my opinion.
Just to add sort of a general point and to echo what Judith just said, one of the my recommendations that has come up in many conversations is, you know, reflective of this cultural shift that many are talking about, which is beginning the conversation, you know, for instance, at the level of the IRB, in which justification is required for exclusion of pregnant people from a protocol or removal from a study drug if they fall pregnant. So just having that conversation among the people who are designing and approving trials, you know, is going to sort of enculturate consideration of the kinds of things we want people to be considering around inclusion of pregnant people in research and getting into that space that Judith was just talking about. So just shifting the burden of justification is what we say.
Yeah. So actually, you know, if this is about starting early and planning early, what was really interesting in the data that Lynn presented, and I have you, Lynn, on this panel, I would like to ask this question. there were certain companies that had the work done early, and many of them were doing it really late. So, but it was not everybody did it with a 6-year lag. Some did it really soon. Lynn, I don't know if you have insights or anybody else in the group, is what drives that difference? It's not that the therapeutic context is so dramatically different because it's all for HIV, right? The data that you, Lynn, you presented. So I'm curious if you have any insights into why in some cases companies moved so much faster than in others.
Yeah, so you mean in terms of the preclinical data, or because the slide I showed was on the PK data?
I see, specifically.
Yeah.
But even there, right? I mean, they moved at a different
right, but I don't think, I think in many cases it was not the company who did the study. It was Impact or the European group. They went ahead and, out of frustration, started up these rolling protocols where they were enrolling women who were receiving the drug anyway because it was being given to women. The women got pregnant, and did PK studies on them. And so it's a matter of the company being willing to let someone else do it. And I don't know that I can explain the differences between the drugs other than that you'd think it would be getting better, but it's, I think, 2 of the drugs that are approved in 2018 haven't yet been studied in pregnancy. So
that's actually, yeah.
Then the other point I would add to that complexity is a lot of these PK studies that Lynn was presenting are all done in the post-market setting.
Yes.
So the clinical studies have already been done at the time of market approval. So it makes it, organizations or academia can actually do these opportunistic PK studies because the non-clinical data is already available.
Right, which is why we need to move it back further. We need to move it back.
And this is going to set us up really well for the next session, which is about next steps and how could we advance this field. So we will take a 10-minute break, or I guess 9-minute break. We will return at 1:40 to talk about next steps. So welcome back, everyone. It's 1:40 p.m. So we will begin again. Our final session of this meeting is entitled Challenges and Next Steps. Panelists in this session will discuss challenges to conducting clinical studies in pregnant people related to funding, scientific barriers, clinical trial infrastructure, and medical legal risks. And they will also discuss next steps to promote and facilitate clinical studies in pregnant people. In this session, we don't have longer presentations. Instead, we have 6 panelists, some of whom you have, from whom you have heard in previous sessions. Each panelist will give some remarks, and then we'll participate in an open discussion to further address the objectives previously mentioned. So our panelists are Katherine Schubert, who is the president and CEO of the Society for Women's Health Research, Christina Bucci-Rechtweg, who is the global head of pediatric and maternal health policy at Novartis, Cynthia Gimfi Bannerman, who is the Ellen Jacobson Levin and Eugene Jacobson Professor of OBGYN and Director of the Maternal Fetal Medicine Fellowship Program, and also co-director of the Columbia University Medical Center Preterm Birth Prevention Center. Karim Kalis, who is Director of Clinical Research and Compliance, Eunice Kennedy Shriver National Institute of Child Health and Human Development at the National Institutes of Health, and Leslie Meltzer Henry. She is a professor of law at University of Maryland School of Law, and a core faculty member at the Johns Hopkins Berman Institute of Bioethics. And then we also have Lynn Yao, who is the director of the Division of Pediatrics and Maternal Health at the FDA. So let me first turn it over to Katie Schubert. Katie?
Thank you so much. So I don't have slides, and we'll take just a couple of minutes. And I see a lot of the comments in the Q&A are addressing a lot of the things that I think will likely come up on this panel. But I think when we sort of consider how do we create an environment that really fosters this type of research and really looks to that culture of inclusion that we're looking for. There are a few things that, from my perspective, I think are really important. One is related to the funding for clinical trials and the inclusion side. So this has been mentioned before, both yesterday and today as well, but really federal funding is the predominant source of funding for clinical trials that include pregnant people. It's really not necessarily a lucrative business on the industry side. And so I think there's sort of a combination of shoring up federal dollars to invest in this type of research, as well as making it more palatable to take it on the industry side. And I think to that point, there's a couple, I noticed in the chat box, there were a couple of comments surrounding incentivizing and carrots and sticks. And I think absolutely that's something we need to consider, but we actually can't even get to that conversation until we really take on this idea of the medico-legal risks. And I know we have a couple of folks who probably will cover that as well. And I know that this will come up later on in the panel discussion. So this idea of, liability and de-risking the research. So there's a couple of ways to do that. Number one, we first have to have the conversation. We can't kind of just jump into either incentivizing this type of research without tackling some of the liability concerns surrounding this. And there's some pieces of the PregLock implementation report that, at least from my perspective on an advocacy side, we can really look to sort of move the needle forward in having the discussion. And I think Christina mentioned this yesterday. It's a really hard, tough discussion to have, but it has to happen. And we really can't think about sort of some potential next steps. There's some things we can do around the fringes, but we can't tackle this issue as a whole without having that discussion. And then the last piece, I think that's really important, sort of outside of the trials design and interacting with the IRB and making sure you have the appropriate experts in the field is related to something that hasn't come up as much. It came up a little bit yesterday in terms of consenting and the process, but I think the idea behind sort of the public education and awareness so that there is an openness to participation in these types of trials and an understanding that it can be done safely and make sure that there's a service to science as well as improving public health and outcomes for pregnant people and their families as well, sort of throughout this process. So I just wanted to throw those three things out there as the panel gets started. Thank you so much.
Thank you so much, Katherine. I think Christina, you're next.
Yes, just let's make sure my volume is working on your end since I'm having some technical issues. Marta, can you hear me?
Yes, and see you as well.
Oh, wonderful. Great. Well, thank you so much again to the organizers for this invitation to participate both in yesterday's session and today. I did give a brief introduction of myself yesterday, so I'll skip over that for today. And as I also, in my prepared remarks yesterday, spoke to some of the challenges, I want to actually focus my attention right now in my prepared remarks on opportunities that I see to move research forward for the pharmaceutical industry so that we can, in fact, be more inclusive of pregnant women in the appropriate clinical research studies. So I'll address what I see as opportunities for the pharmaceutical industry through the headers of funding, science, and medical legal risk. And you'll hear some similarity in what I'm about to say to what Katie just said and to what some other speakers have already said this afternoon. And I'm going to defer any comments on the clinical trial infrastructures to our panelists who are more actively contributing to the research space. So if I focus first on funding, I had mentioned yesterday that there are two key drivers for industry to invest in research. One being demand, which will push researchers and commercial entities into research, and two is technologies or understanding of high science to facilitate basic science and foundational research, which ultimately informs how we identify new therapies to bring forward. So demand and technology similarly are also at the heart of funding decisions. So if there's neither demand nor technology, the push and pull of these drivers are going to lead to suboptimal funding as well to all of the sectors that are involved in the research enterprise. And unfortunately, we've seen that innovation in pregnancy research is a clear example where demand and technology have been wanting, in particular as it relates to the therapeutics development for investigational agents specific to pregnancy. So from my perspective, and thinking about this from an industry standpoint, if we're going to move demand and technology forward, one thing that is an enticement clearly is policy initiatives that will incentivize research to trigger investment of resources for novel development of assets to address the diseases and conditions that are specific to pregnancy, so that we actually, in fact, end up seeing these assets come from the bench to the bedside. So how about on the science side? And similar to what we've observed in the field of pediatric research, sometimes scientific decision-making is routinely trumped by ethics of research. That's not to say that there should not be ethics involved in our decision-making, but what I am trying to say is that ethics alone should not be the basis whereby we're making our decisions. So to address this, we have to, as the stakeholders, reinforce and build our understanding of disease biology, molecular mechanisms of disease in pregnancy, the appropriateness of trial endpoints we're using in patients who are pregnant, also on the on and off target activity of novel mechanisms of action during pregnancy. And it's only when we have a strong foundation in the science will we be able to move this forward. So from my perspective, funding and science are intimately intertwined. So there's an essential need to invest in foundational science to better inform not only on disease processes, physiological processes in pregnancy, but also models of disease that will be essential to helping us use and leverage models to determine dosing to predict effective new therapies in pregnant patients. And hence, we're back to the adequacy of funding so that we can ensure access to data for trial design and decision-making that ultimately will allow us to be more inclusive of pregnant patients in our research. And finally, I'd like to focus on medical legal risk. And I'm really excited to talk about this topic with the panel. And I have been paying attention to all of your questions in the Q&A. And I noted yesterday that there is a paucity of information to inform on newly authorized products for both dosing efficacy and safety when used in pregnancy. And as a result of this, it is very clear that patients are assuming the burden of risk when taking a prescribed medication for newly authorized therapies. And clearly this should not be the case. So as a community of stakeholders, we need to commit to finding a reasonable solution that will de-risk the research endeavor, just as Katie said, for all of our stakeholders, so that sponsors, regulatory agencies, disease experts, and prescribers are better equipped to provide information to patients that are going to more robustly inform on both the benefit and the risk in pregnancy and throughout the course of pregnancy. Thus, we need to distribute the risk more equitably across all the stakeholders and just not leave it in the hands and on the backs of the patient. I have seen and heard mentioned a few times that we should study pregnant populations earlier in our clinical development programs. While I don't disagree with this sentiment, there are some instances where we may or should be able to do this. And we should be able to do this, for example, when the mechanisms of actions are well understood or the effect of the therapies are well understood. However, we have to also be grounded in reality that we're in the innovative sciences and have a lot of novel mechanisms whose reproductive and developmental risks to a fetus are completely unknown. So it'd be really naive of us as stakeholders to assume that we can just universally apply a desire to go earlier in pregnancy across all of the investigational drug pipelines without generation of data that will help us to de-risk from the standpoint of data to inform appropriate application for not only the patients, but for the research investigators, our sponsors, and clearly our trial participants. So just as Katie said, and I'm going to repeat exactly what I said yesterday, this is a very difficult conversation, but we need to have a conversation on how to mitigate risk. It needs to be initiated between us and understood across us and find a solution that works for all of us. But we need to not only have conversations, we need clear and definitive reform introduced, and it needs to be undertaken in a manner that will de-risk human research evaluation for all the stakeholders engaged. And this is actually a wonderful moment as I see it, because I'm thrilled that we have legal and ethical committee membership that's on this panel today, and it should make for a robust conversation around all of these themes. So thank you very much for this opportunity.
Thank you so much, Christina. And if I could now turn to Cynthia.
Hi, how are you all? And hopefully you can hear me well. I just have a few prepared remarks. First, I want to just state how much I've enjoyed the past 2 days. Thank you for inviting me. As just noted, my name is Cynthia Janfi-Bannerman, and I'm an obstetrician and maternal fetal medicine specialist at Columbia University in New York City. As a clinical trialist and a pregnancy clinical researcher, I can also confirm that some pregnant people are very interested in participating in clinical trials if they are given the chance. As was mentioned previously, the NIH mandates that investigators justify exclusions based on age, race, and other criteria, but they should also strongly consider making investigators justify why pregnant people are excluded in their trials. In terms of prioritizing pregnancy conditions, with the recent and justified focus on maternal mortality, one approach would be to prioritize those that are most likely to kill the mother. These vary by part of the world, but traditionally have included preeclampsia, hemorrhage, sepsis, thromboembolic disease, and maternal cardiovascular disease. For example, our group, which is the Maternal Fetal Medicine Unit's network investigators of NICHD, are currently working with the FDA to study pravastatin, a very promising drug in pregnancy that could prevent early and severe preeclampsia. Another approach is to study drugs for the most prevalent chronic medical conditions that we see in pregnancy, such as chronic hypertension or pre-existing diabetes. All of these studies should ideally include long-term follow-up to assess the health and neurodevelopmental outcomes of the offspring, as well as potential benefits and long-term for the mom as well. There is somewhat of a disincentive for industry and other funders to create medication specific to pregnancy conditions, as pregnancy is a 40-week period. Less really once a person even knows that they're pregnant. And developing a drug that would be in use for a few months has less perceived return on investment, let's say, when compared to developing a drug that is used from a chronic condition, such as elevated cholesterol, which could, in theory, be used for decades. Some of the challenges in conducting clinical trials in pregnancy are related to the outdated and paternalistic need for paternal consent to enroll in clinical trials. It seems to belong in the 1950s, as families have evolved greatly since then. There is so much to say on this topic, but I will leave it at that. Another challenge is that we always have two patients, so the pregnant individual and the developing fetus. It's not enough for us to follow the mother until 6 weeks postpartum. Study follow-up should be at a minimum for 2 to 5 years of age of the child. And current funding mechanisms make this kind of follow-up financially impossible. I'd like to end on a positive note. Meetings like this one are a great start. The COVID pandemic has also acutely showed us what happens as pregnant people were excluded from vaccine trials, even though they're at highest risk for disease from COVID-19 once infected. I applaud the Society for Maternal Fetal Medicine, the American College of Obstetricians and Gynecologists, and eventually the WHO, who advocated for vaccine access to high-risk pregnant individuals. I think all of these are positive steps towards including and protecting pregnant people in clinical trials. Thank you, and I look forward to the Q&A.
Thank you so much, Cynthia. And if I could now turn it over to Karen. Kareem, you might be on mute right now. There we go.
Okay, thank you very much. I appreciate that. So I would like to start by saying that I'd like to thank the organizers for including me in this very important workshop related to a topic of great personal interest. I'm a clinical pharmacist with training and experience in clinical research and public health, and I am the Director of Clinical Research and Compliance for the National Institute of Child Health and Human Development at the NIH, and have worked for many years in the area of women's health and reproductive endocrinology with a focus on primary ovarian insufficiency. I'm also chair of the NIH Institutional Review Board in the Office of Intramural Research. So just kind of briefly, I'd like to say a few words. So clinical research in the pregnant population is an obligation and a public health imperative. The pregnant population is clearly underrepresented in clinical research. And even today, in 2021, many of our clinical protocols remain silent altogether about pregnancy. The PregLac recommendations and FDA comments and guidances clearly endorse and advocate for responsible research in this population. We can all make a compelling case for conducting studies to improve pregnancy outcomes and to study common conditions that coexist with pregnancy. And over the past 2 days, we've talked a lot about the need for additional data on drugs and therapeutics that are already approved and commonly used in pregnancy. And we've discussed innovative approaches and study designs to generate the data and evidence to help in the effective health management of this population. And I think it goes without saying that none of us would purposely expose a pregnant individual or fetus to undue risks. However, one thing that I think we need to consider is in weighing the risks and benefits of the research, we can't ignore the inherent risks from the absence of data and evidence that's needed to help us provide optimal care for this population. So the question is, how do we go from advocating for the responsible inclusion of pregnant individuals in clinical research to making it a reality? And I think that's what we've been trying to talk about for the last 2 days. So first, and you've heard some of this before, is first we need to incentivize investigators. We need to more targeted funding for pregnancy-related research, and we need to have an end goal in mind, and that's generating the evidence that we need to improve prescribing in this population and improve the overall care of pregnant individuals. So how do we do this? How I would argue that there is one primary barrier that remains, and that's the attitudes and culture. So I'm talking here about the attitudes and culture of investigators, funders, and review bodies, including IRBs. And so the question is, again, how do we overcome these barriers? Well, first and foremost, I think we must establish a culture of inclusion with a focus on diversity and access to clinical research. And we need to develop effective strategies to help close the gaps that currently exist as they relate to the inclusion of pregnant population. The new paradigm that we've all been talking about shouldn't start when we're reading about a published study report in a New England Journal of Medicine or another major medical journal, and then ask why pregnant individuals weren't included in the first place. The process, to my mind, would actually necessarily start from the very early stages of study conception to study design, and then continue into the scientific review process, and ultimately as part of the IRB review process. We've talked a lot about the role of the IRB, but the IRB should not be the first to address this issue. IRBs have a critically important role in carefully balancing both ethics and science to ensure the safety and welfare of human study participants. And I've been serving on IRBs since the 1980s. The IRB relies in part on a robust scientific review process, which would include subject selection and the appropriateness of the study population under consideration. Particularly when protocols are silent on the issue, though, IRBs may incorrectly assume that there is a scientifically or medically valid reason to justify exclusion of a certain population when a valid reason may not in fact exist. Now, just switching gears slightly, I want to just I'll touch briefly on the regs. I want to say that you all recall the vulnerability designation. That was in some way a convenient scapegoat that I think stigmatized research in the pregnant population and accentuated the risks or the sense of risk and perpetuated a sense of fear of studying this population. Well, that vulnerability label, as you all know, is gone. And of course, we still have the subpart B protections that are intact under the revised common rule. And we certainly need those protections in place, but protections are there for a reason and should not be minimized. However, the language in the regs must be updated to reflect current priorities and minimize risk-averse thinking that creates an impediment to needed research. One other last point that I'd like to make is that we've all talked about this issue of justification for exclusion. And I raised this point in my presentation at the PregLac meeting in 2017, because this is something that I think is critically important, and a number of other panelists have brought this up as well. If specific populations are excluded, investigators must provide a clear and compelling rationale and justification to establish that inclusion is in fact inappropriate with respect to the health of these participants or the purpose of the research. So some criteria often considered for exclusion are pre-existing conditions or current diagnoses, concomitant medications or devices, known allergies, number of other factors that can cause harm or increase risk to the study participant, or preclude the participant's full adherence or completion of the study. Now, if the eligibility criteria exclude any population from the study on the basis of factors such as race, ethnicity, sex, disability, national origin, age, English language ability, etc., there are a number of these things, then we would typically ask for a justification. We need to add that pregnancy in that list. So anytime that an individual is excluded, we need to understand why, and we need to understand that there's a valid rationale. So ultimately, we need advocacy, education, and increased awareness about specific considerations for research in pregnant women. And the key to overcoming some of these barriers would be these consideration of these things. But we need to start with guidelines that can be operationalized at the institutional level. I think that's where we're sort of, things are not, we're all talking a lot about these things, but we're not turning them into actionable items at the level. We're focusing sometimes on the regs and this and that, but I think the culture is really important, and we can talk about that a little bit later. But also we need to overcome some of these barriers, and we need to start operationalizing these things, including justifications for exclusion. So I'll stop there. Thank you.
Great, thank you so much, Kareem. And if we could next turn to Leslie.
Thank you to both the Duke Margolis Center and also to the FDA for the opportunity to discuss the legal landscape that surrounds and shapes decision-making about whether to include pregnant people in research. I have no conflicts of interest to disclose, but I do want to acknowledge the contributions of my frequent co-author on this issue, Anna Mastriani at the University of Washington School of Law, and other members of our team as well, including Sarah Wicks, Robbie Franceschini, and Adrienne Simonelli. In the time we have, my plan is to give you a brief tour of the legal terrain in which decisions about the inclusion of pregnant people in research takes place. I'll be focusing on 5 key features or points for your consideration. There are, of course, many layers of legal complexity in this setting that warrant our attention, but these landmarks, if you will, provide some orientation as we begin to map out our next steps. First, there is, as we've discussed over the last 2 days, an unfortunately but deeply entrenched myth that it's legally impermissible to include pregnant people in research. In 2015, Anna Mastriani and I invited lawyers with different roles along the research pathway, from general counsel at major pharmaceutical companies and academic research institutions to former government regulators, to talk with us about the factors that influence decisions about including pregnant people in research. Our results, which were published in 2017 and confirmed in a subsequent study published by Christine Shields in 2019, reveal that some decision makers responsible for approving research continue to believe that FDA regulations bar the inclusion of pregnant people in clinical studies. This false perception is not isolated, but spreading. In court documents we've recently reviewed, the claim that it's legally impermissible to conduct research with pregnant people has been propagated by pharmaceutical companies as a legal defense and then reiterated by judges in subsequent court decisions. Yet all of us know that clinical trials with pregnant people, while not as common as we might like, are illegal and are taking place. Making progress in this context then requires outreach and education, as well as easily accessible examples of approved research with pregnant people that might serve as a guide to legal decision makers who have scant knowledge of what others in the same or even a similar position are doing. Second, this myth is amplified by a constellation of either absent or ambiguous regulations. First, there's no legal requirement to include pregnant people in research or to collect data on those who become pregnant during research, and there's no incentive to do so. I'm going to come back to this in a minute. But second, in the face of this regulatory ambiguity, most decision makers engage in a cautionary interpretation. Let's think for the moment about those who are subject to the requirements of Subpart B of the HHS regulations pertaining to research with pregnant people, the concept of minimal risk. The regulations define minimal risk in terms of harm ordinarily encountered in daily life. But there is no common understanding of the risks encountered in the daily life of a fetus. Further, Subpart B doesn't provide guidance on whether those risks should be understood differently when the pregnant individual has an underlying disease or condition that may have an impact on fetal well-being. It's also unclear whether minimal risk should be interpreted the same for every phase of pregnancy, or whether there should be an acknowledgement that risks to the fetus change over time. In the absence of clear guidance, Subpart B tends to be interpreted conservatively, resulting in the frequent exclusion of pregnant people from research. Third, there are tangible monetary and legal benefits to industry when they exclude pregnant people from research. Inclusion of pregnant people may add costs, may add time to the R&D process, as well as delays, arguably, and potentially to the approval process. Meanwhile, exclusion from research available to industry because there's no requirement to include pregnant people provides industry with two types of protection from liability. First, pre-market liability. By excluding pregnant people from research, industry eliminates the risk of liability to them for harms to pregnant research participants and their potential offspring. But second, post-market liability. Without scientific evidence to guide prescribing decisions, healthcare providers and their pregnant patients are forced to make clinical decisions, often with nothing more than anecdotal evidence. If something goes wrong, industry has a defense. They had no data suggesting a risk to pregnant people or fetuses, and their label said so. The law, through a mechanism called the learned intermediary doctrine, shifts liability downstream to the prescriber. The result is that all of the risk is borne by healthcare providers and their pregnant and lactating patients. This gets us, of course, to fourth, the elephant in the room, fear of liability. It's the most frequently cited reason that industry and other stakeholders give for not conducting research with pregnant people. But a careful examination of legal cases reveals that the fear of liability far exceeds instances of actual liability. We repeatedly heard in our discussions with industry representatives and other stakeholders, including academic institutions, that they don't want to be liable for the next thalidomide. But that thinking has it backwards. Liability in that case resulted from a failure to include pregnant people in research. To the extent that it exists, the risk of incurring liability during the early stages of drug investigation is relatively small, while the risk of substantial liability, as in the thalidomide case, is much greater once the drug enters widespread use without appropriate and important experimental work being done. Fifth, and finally, I want to encourage us to think about the inclusion of pregnant people in research is a critical public health issue that requires us to leverage public health tools across many domains. It requires investment throughout the research pathway and even outside of the research enterprise. Lawyers knowledgeable about this space can help stakeholders engage in a lot of different creative risk mitigation strategies. And each of the issues I've discussed above can be addressed. One mechanism that I've written extensively about is compensation schemes for research-related injuries. When carefully crafted, these schemes can dampen disincentives to include pregnant people in research. To echo what my colleague Karim Khalis said earlier, however, there also must be culture change. Anna Mastriani and I recently published an article that examined a variety of factors that facilitate research with pregnant people at one institution, the University of Washington. Notably, the University of Washington is one of the only academic research institutions that has a program for compensation for research-related injuries. By making that institutional commitment and other commitments, including a clear regulatory interpretation of and a commitment to research with pregnant participants, as well as a collaborative IRB review process, the University of Washington has not only addressed some of the disincentives of doing this research, but has also created a backdrop against which decision makers can be more assured and less conservative when it's not necessary to be conservative in their decision making. In conclusion, and that was a very quick tour of the landscape, we need to take steps to make this legal terrain look less like an unnavigable jungle and a lot more like a well-traveled and easily demarcated path. The more research we do and the more examples we provide that this research can be done responsibly, ethically, and legally, the easier this process will become. Thank you.
Thank you so much, Leslie. This was a very quick overview of an issue that is really of great interest, I think, to this group. So we will definitely be coming back in the discussion to a lot of these legal concerns and how valid they are and what one could do about them. So thank you. And then if we could turn it over to Lynn for some remarks before we move it to a broader discussion.
Great. Thanks, Marta. And you know, I have the very enviable position of being last in the conversation today. So I'm really excited that I get a chance to consider everything that's been said so far in the last 2 days and provide a few thoughts before we move into further discussion. The first thing I'll say is that I have a few prepared remarks, and as people were speaking through the course of the last 2 days, I've been crossing out, and crossing out some more, because so many of the things that I wanted to mention or bring up have already been said. So I don't think that it necessarily needs repeating most of the things, but I will just provide then in a couple of minutes my thoughts on some of the items that were intended to be a part of this session. The first concept I want to bring up is this notion or this need or this belief or this marching order that we have that the collection of high quality data to support the safe and effective use of medicines during pregnancy and lactation is inarguably good, right? I mean, that's, you know, we hold this truth to be self-evident. This is something that we all believe. And what I hear now and what I think the purpose of these 2 days is to take that marching order and move forward with it. How do we do that? So I'm going to provide you a few personal views on how I think we do that. Now, in terms of the funding, I'm not going to go into that because I'm not a funder. I failed to mention that I'm, you know, at the FDA, as you can see by my background, and definitely been involved in the last several years on how we improve the landscape for the safety and effective use of drugs in pregnant and lactating women. And then, of course, certainly I've been involved in the pediatric space. In terms of, you know, the need to move things and move preclinical, non-clinical studies earlier, to get PK in earlier when we can, the appropriate timing, I think that's all been said very well. And I want to thank Lynn Moffinson for providing a terrific talk earlier today. You know, I also just want to make the point, although I'm not a money giver, I'm not a grant, I'm not a grant writer or a grant, I'm not a granting authority, and I certainly don't work in industry and know how the budgets of industry work. But one of the things I know in general is that, you know, the earlier you know you need to do something, the sooner you can budget that requirement in. And I think that if we all are in agreement that some of these things have to be done, then I think it makes sense for those who need to budget that in to know that that's required. And so I think that even without the ability to potentially increase funding across the board, that just knowing that that needs to be included hopefully allows for people who are in those money granting situations to understand the importance of that. In terms of scientific and regulatory barriers, I mean, I think that some of the questions, really terrific questions in the Q&A, and the comments that have already been made by Yodit and Katherine and others, you know, described that, yeah, of course, we want to use all the data that we can, and all the available data that we can help support maybe doing something less. And that's certainly a concept that's, I think, I have learned greatly from on the pediatric front, that we have an obligation to take all the data that we have, review it to see if it can be leveraged to do something less. That certainly includes the idea of PBPK, that includes the idea of leveraging safety in all areas and arenas that we have it. And that certainly applies to the information that we get from non-pregnant individuals and how that's applicable to the pregnant population. I also think that in deciding, you know, where the sweet spot is the idea that, you know, again, as a regulator, we want to do the right thing. We want to make sure that we don't allow something to be approved that's unsafe or allow something to be approved that's ineffective. But there are many creative ways that we can get to that information. And I think that, for example, I think I heard Susan describe, you know, the idea of pregnancy registries that are very hard to enroll and using claims databases or other ways to get that information. And I think, or that pharmacologic or pharmacovigilance, routine pharmacovigilance can leave a lot to be desired. And I think between those two extremes, we can find a process and a method to collect information that isn't going to necessarily give us uninterpretable information on one hand or infeasible studies on the other. In terms of just the last comments I want to make, I feel like, and I heard this best from, I think, Annie just now, really terrific talk, and also from Leslie just before me, really terrific. I mean, that's probably the most I've learned in 5 minutes about, you know, an interpretation or an understanding of medical legal risk. So that was really impressive that you were able to do that, Leslie. But I think that maybe one of the things that we need to do, this is one of my potential ideas to move forward, is the creation of a lexicon that we all begin to use together in whatever area we work, in whatever, you know, domain is our area of expertise, to help to change that culture, to help to reinforce the ideas that we've brought forward today. Some of the lexicon has already been created. For example, justification of exclusion. For example, you know, we want to encourage, or we believe that women are protected, pregnant patients are protected through research, not from research. And I think another idea that I think Annie was bringing out today very clearly to me was this notion of intertwining of the mother and the fetus. And that intertwining is not so easily separated, either ethically or scientifically. And it sort of encapsulates one notion that we've been trying to move forward as well at FDA, and that is that the health of the child begins with the health of the mother. And so I think that, you know, bringing these kinds of, I don't necessarily mean to call them catchphrases forward, but the idea that we operate with a common set of terms, I think really will help to educate and advance our ideas. Finally, the one last idea that I had that I wanted to bring forward before we open up the discussion is brought to me by my colleague, Janet Nooney from MHRA, from the Medicines Healthcare Products Regulatory Agency in the UK. And she thought that one idea, and she gave me permission to bring this forward, but she thought that one idea to improve transparency and also maybe to change culture, to provide more information to those of us working in this space, is to create something like a registry or a listing or a website that includes all of the trials that are actually enrolling pregnant women. Something that's a little bit easier to navigate to that spot than clinicaltrials.gov, maybe even something like Preg Trials or pregnancytrials.gov, something that is an easy source for us to gauge our effectiveness, a way to measure improvement in how many trials are actually enrolling or allowing pregnant women to remain in a clinical trial, something like that. But then also to have a converse, which is how many trials out there that are actively excluding. And if they are actively excluding, as I've heard Kareem and others say, then in that short description must be the justification for that exclusion. So I want to end my remarks there, and I look forward to the discussion that we'll be having now. So thank you very much, Marta.
Thank you so much. So let's put up the slide with the discussion questions. We will now move to a full discussion for the rest of the time. So let me read these questions and then we'll actually go to the gallery view. And we won't necessarily go over these questions in this order because these will be coming up, but I think there's a lot of other questions that we might want to be asking. So what are the current resources? What current resources exist to assist clinical investigators in obtaining feedback and as they proceed? What are the top priority conditions impacting pregnant people that should be addressed first? So questions around how do we prioritize? How can industry, academia, regulatory stakeholders, and NIH best collaborate? What opportunities are there for public-private partnerships? What are the greatest challenges and what are the potential solutions to conduct clinical trials during pregnancy? And how do we foster education and awareness about available resources and requirements? So if we could actually go back to so keep these in mind, they are actually in the agenda, so you can have those in the background. But what I would like to propose is that we actually I think what would be really helpful in this session is if we really dive in and come out with specifics, with things that could be done, that what would it take to move the needle, and who needs to be involved. I think that's really important to delineate. So if we could have all of the panelists for this come back on video. But I also wanted to offer up a little bit of a twist for this session. Now this is really a final session and we have all of these subject matter experts that have participated throughout this conference. I won't be asking you to all go on video now because we will not fit on one screen. So what I would like to propose is those who are in this panel, please stay on the screen. If you, as somebody who has been on a different panel, would like to jump into a conversation, please turn on your video. This is a really good cue for me that you really want to participate in this discussion. And frankly, this is a good way for us to kind of stay on topic and dive deeper. Also for panelists or anybody else who is going to be on video, raise your hand. It really helps as a cue to say, I really have to follow up on what's being said. And I think we can get a deeper discussion of topics like that. So if I could ask that, Kaylee, if you could switch us to the panel, the gallery view, that would be great. So I wanted to perhaps start with the question around actually, perhaps we start with sort of the question that's been sort of popping up frequently around that Leslie spoke about, which are some of the legal challenges and how much of a barrier it is and how many myths there are around this. it would be really great if we could, if this is really almost, it almost sounded to, and I'd be actually curious, Leslie, whether you think it is what I would call a necessary condition for us to overcome this, that this seems to be an obstacle large enough that we need to tackle this issue. And so the question is, how could this be tackled? If you could sort of give us your top few solutions to this, and specifically point out who would need to take a lead on those to sort of help advance this. Clearly, education is a big part of it. We need to change the culture, but again, how do we do that? Yeah, Christina, I'll come to you. I'll have Leslie start off, and then I'll go to Christina.
I think it is an excellent question and one of the hardest to answer. In the Hastings Center report article that I mentioned earlier from 2015, in which we interviewed stakeholders throughout the pathway, that is, from my perspective, where you start. You have to start with the stakeholders. You have to have the relevant buy-in, and you need to get at the touch points throughout the research pathway where these decisions are made. What we learned is that a decision at any point in the research pathway, from the very early animal studies to post-market decision-making, lawyers are embedded in that process all the way through, and so are other decision makers who read regulations or see the lack of regulations and are making decisions that might be considered legal decisions, or at least based on what they perceive as legal implications of their decisions. And so having clarity with those stakeholders about the permissibility, first, of doing this research, and then second, about the mechanisms in place to assist them in doing this research is really critical. That does start with education, but it also starts with institutions committing to doing this kind of work. It's not easy work. It can take more time, and you need to have institutions that are invested in making that happen as well.
So this is, for example, your University of Washington example, right? That they actually set up a fund. So can I actually ask a follow-up question? Does this mean that every university and every basically every trialist is going to need to come up, with a fund like this? I mean, is this a feasible? Is this an efficient way to do it? Would you have recommendations about, if you want to see progress in this space, do we expect one university after the other trying to adopt it, or is there another way to do it?
There is a federal option through the NIH grant funding policy program. It hasn't been used before, with the exception of the international context. So most countries outside of the United States, regardless of where they're located, if US researchers go to those countries to do clinical research, they're required to have clinical trial insurance or some sort of indemnification policy to account for research-related injuries that occur during those studies. And they have to have evidence that they have that insurance before they can start the study. Those that are NIH funded are actually able to use part of their grant funds to pay for that kind of clinical trial insurance or create that kind of indemnity fund, but only if the research is taking place outside of the US. So there is the possibility for a policy change there, where one could envision that individuals apply for grant funding with some sort of risk assessment about the likelihood, though this is difficult to do, of having an adverse event that might require some form of compensation, and that could become part of a grant fund. That's one mechanism. There's other mechanisms as well that we can talk about, but in the United States, there's no general requirement to cover research-related injuries. Most institutions tend to settle out of court one case at a time.
Christina, you wanted to speak.
Yeah, and I think Leslie's points are all right on the mark, but I also think that they're looking at one stakeholder group. So the reality is risk mitigation is different for every stakeholder involved in a research endeavor. So actually the solutions in this particular topic of medical legal risk need to be addressed for each of the stakeholders for any of this to move forward. And if we only address it in one stakeholder space, it will still not address the challenge. So I think that that's one of the things we have to start with. I also think that there's gradations of risk also dependent on the type of therapeutics we're talking about. if we're talking about products that have been standard of care in the medical marketplace for decades, but yet there's not a complete set of information to inform on dose, there's a different level of risk for clinical research with those products than those products which are truly novel. The mechanism has never been evaluated, and we have no human data as yet to inform on the risk to the patient that is enrolled in the study and their developing fetus. So it's a very highly complex environment that needs multiple solutions to address each of the different levels of gradation of risk. But I fully support Leslie in that there are clearly solutions we can get to. We just need to have the fora to get the right people at the table to actually move this bar forward.
So Christina, let me just ask you, and then Lynn, I'll go to you. So who are the right people to bring to the table? To be a little bit more specific, right? If you want to move the needle, you know, this is complex. It's all very contextual, but if we want to move the needle, we need to sort of start identifying very clear next steps. So who would be the people to bring to the table, and who are the players for whom we need to be thinking about de-risking? And how do we, is there a process through which we want to follow to consider, okay, so let's say we look at this stakeholder, given the complexity of this, how do we think about de-risking them? Do you have any thoughts on that?
Yeah, and I would be inadequate to answer this solely by myself, so I can think about it from an industry perspective. Leslie was 100% correct. In the innovative research endeavor, there is legal counsel at every stage of the process, and they all actually play a slightly different role depending on the process that we're in. There is a big difference between an IP attorney and our patent attorneys. And so the risk between the advice they're giving are very different. But as it relates to the risk at hand, given the stage of the product, there would be different individuals within the legal community who would need to be at the table. Clearly, there would need to be individuals at the table from the legal community, both from the standpoint of those who represent the innovator perspective and those who represent the malpractice perspective, et cetera, et cetera, et cetera. So from my perspective, I think we need to start with some of those voices, which I think there's actually been quite a few of them that have been largely absent from the conversation up to this point.
So just one more follow-up question, Christina. So who could be convening them? Is this a place for FDA to be convening? This seems to be a very different environment. Do you have the, American Bar Association? How do you think about the party that would be convening it? Do you ask industry to convene groups of their own industry lawyers to do this? I'm just curious how we could take the steps to actually start these conversations, and who could be
from my perspective, the only way to start the conversation is with a neutral convener. I think if we go with one stakeholder's body, we'll miss the boat. We'll end up convening a group of people who are thinking like and not seeing the perspective from the other perspectives, and we won't end up coming to a place that will allow us to find a solution to move forward.
I would suggest potentially a NASM group to meet and get all the right stakeholders in the room. I know we have referenced a lot of reports over the last couple of days, but I think that there really probably needs to be, and if you look at the PREGLAC implementation report, it says a lot of what has been discussed, but it doesn't get into the nitty gritty because frankly, those experts weren't necessarily in the room, and there were a lot of other moving parts. So I think it has to be a third party. It has to be a really inclusive conversation and something that really provides actionable steps, even if it's sort of a stepwise implementation approach for this to get all of the different aspects that are necessary to move it forward.
I just wanted to add that part of framing this as a public health issue is placing this into the hands of a nonpartisan but scientific working group. And so I think so much of this is about the frame in which we think about it. And if we think about it that way, then the government is the appropriate place to convene this sort of a working group. And I know PREGLAC came out of the 21st Century's Cures Act. Now I think we have information and a framing to take it further. And there's lots of institutions that could be right to convene it. I don't think the American Bar Association is likely one of them. I'd really love to see this be a broader group of public health, medical, scientific, industrial, and legal experts.
So I know, Lynn, you wanted to chime in as well on this topic. And you're on mute right now.
Thank you. So I had a very basic and probably naive question, but before that, I wanted to also support Leslie's comment that, you know, this is a public health issue. It is squarely, absolutely front and center, a public health issue. And in convening this group to work out and figure out where, you know, who needs to be there to get to figure out a path forward, that it is, I think, at a very basic level, look, this is not, this, you know, we want to identify the places where the path may be less well-traveled, but we have to create that path. It's not like we throw our hands up, as Leslie said, and it's a jungle and, oh, well, I guess we can't do it, right? It has to be with a group of people who are dedicated and understand the various spheres, these legal areas that, you know, we need to have expertise there, but with the idea that at the end of the day, we will have created some sort of path that can be followed. And then my very, very basic naive question is, how is it that informed consent, which we believe helps us to cover, you know, the many sins potentially of, you know, something that might go wrong in a clinical trial, how is informed consent used differently or viewed differently in this context? Because women, as we've said over and over for the course of the last 2 days, are able to make decisions for themselves and are actually want to, are motivated to make those kinds of decisions.
Yeah, and actually, I see Cynthia nodding here a lot. I mean, a lot of what Cynthia spoke about is pregnant women do want to people want to participate in trials. So the question is, I guess, how do you engage be patient advocates and organizations to be part of this conversation, right? Because it seems like they would be great allies in this fight. So I guess Cynthia and Katherine can very much speak to that.
Yes, well, I was nodding and smiling because I think maybe for the first time in my life, I felt a little bit like a unicorn because I do clinical trials on pregnancy all the time and actually live in a community of people who do clinical trials on pregnancy all the time. And so I do think that silos are a potential part of the problem. The patients that I see are quite used to that because of the culture here. And I do think that, first of all, it's an obvious public health issue. I mean, again, using COVID as an example, pregnant women get sicker, or pregnant people get sicker than non-pregnant people with COVID, yet they were excluded from the trials and there was no justification for it or no need to justify that. And now, on the other hand, rather than protecting a woman through the clinical trial and watching for all of the severe adverse reactions and monitoring them daily, the alternative is, well, go ahead and get the vaccine, put yourself in a registry maybe, you know, answer some questions and we'll kind of figure it out. And that's what we've been left with. And, you know, so I do think that first we do need we need to dissociate the stigma with research in pregnancy. That's I think incredibly important. And then I do think that for folks who are developing trials who are maybe not used to working with pregnant people, there's several of us who do this all the time and who would be happy to help them develop these trials and use all of the resources that we have and the infrastructure that we have to understand what we do with our pregnant people, because those are the only people that I do research on.
So I see Kareem was raising his hand. So if you wanted to, and you're.
Thank you very much, Marta. I'll be brief. I just wanted to come back to a point that I think we keep forgetting about, and that is the point that so many protocols remain silent about this whole issue. So I'm talking even from the inclusion, exclusion part. And I think, so we're talking about, well, you know, about bringing people to the table, whatever. Well, if it's not even on the table, you can't begin to address it. So to my mind, the first step is really an outreach at the institutional level, you know, with regards to the people who are funding and conducting the research. Those are the places where we need to begin. That's where we need to start the process. And because, as I mentioned in my earlier comments, we need to start at the conception phase of the research. That's when there's interactions, there's discussions about the science and about the ethics and about what have you, or there should be. And if it's not being done at that level, then there's, you know, down from that step, it doesn't get addressed. So we need to bring it into, we need to template it. We need to build it into the template so that to force the investigators to at least raise the issue so that it can then be raised in the scientific review process. It can be raised in the IRB review process to get it to the table so that it can at least be addressed.
Yeah, so let's stay on the sort of how do you create these. So there was in the Q&A, Evan Myers mentioned that the Duke IRB has a vice chair for reproductive risks who reviews all protocols, both for justification for exclusion of pregnant people and the appropriateness of the methods used, pregnancy testing protocols, contraception requirements, etc. I guess in terms of sort of setting these set of expectations and setting these, making sure that it's on the table, I guess a couple of questions. One, this might be something that would be great to duplicate, but again, should this be at a university level? Are there things that for example, NIH and FDA could be doing, kind of back to Lynn's point about, making sure that this is an understanding that this is how we do it, right? And so what could be done what are some of the tools that could be used, not just to inform people, but to actually change some of the structural things, such as, one of the things that have been mentioned is let's make sure that NIH studies say that you actually have to explain why you didn't include pregnant people in the trials, right? So that was, for example, one type of a change. And I wonder if you have other ideas of what could be some of the things that structurally could change in a way that could put it on the table. I don't know, Christina. Yeah, but okay. I'll go with Katherine first quickly and then to Christina.
I was just going to really quickly say, I think there's sort of two pieces here, right? Is and I don't know who has authority and what authority might be needed. So I would throw that out there. And that's something that on the advocacy side, we would need to look at. But I think justifying why the population is excluded is really important, whether that's at the NIH level or FDA being able to ask that question, so that even at the most basic level, even if someone isn't thinking about it, it forces you as a researcher to just stop and think, oh, why are we doing it? Just because that is what we've always done, or does that change it? And we saw that it does help when we look particularly to the NIH policy on sex as a biological variable. So there are mechanisms to do it, but I guess my question back to the group would be like, is there authority already to ask that question? What are the sort of policy levers? Is there something that HHS wide, there needs to be a rule or something like that would need to be considered as you're thinking about that?
I'll go to Kareem since this was a NIH specific, and then I'll come back to you, Christina.
Yeah, this is, we don't need to change the regs for this. This is something that's inherent in the process and can be addressed for any population under study. So in fact, I went back to our list of, justification for exclusion in the NIH intramural program, and I didn't see pregnancy listed, and we're adding it now. But as an example of the things that you need to justify exclusion, for exclusion and so forth. So what I'm saying is we all need to address that at that level, and we don't need to change regs or whatever. We're talking about best practices as they relate to research, and we talked about the attitudes and the culture and whatever. It does take time. I understand that, but I think you're asking, what can we do right now? How can we get this out? I don't think you need the government. I think you gather stakeholders. We've already, the PregLac recommendations are already out there. A lot of other things are already out there advocating for this. I think we have to be very practical at the level of just changing even the template. FDA has a template for protocols. It should be there in terms of FDA regulated protocol. NIH for intramural protocols. So, and it should be something that would become sort of a best practices issue. And we can publish that. We can, there are guidelines that can be promoted and so forth. But I think it really is addressed at that level. I don't think we need, the regs may take years to change. But I think these are sort of simpler things. But we've got to bring the issue to the table because it's often ignored, even among people who really know better.
So Christina, I'll turn to you, and then after that, we'll switch gears a little bit to talk about funding, actually, because that's another big concern here. So Christina, go ahead.
And probably Lynn may or probably should follow up after I make my comment, but I fully agree with what Kareem is saying. I don't think that this is something that requires a regulation to change. I think this is purely an implementation issue. I think justification for exclusion comes standard with so many other aspects of our protocol that this is a relatively straightforward process. And please, for those who are not aware, understand that we have multiple conversations with regulatory agencies across the globe about our development programs, about our reproductive toxicology programs, about our pre and postnatal development programs, about our populations for inclusion. So it would be, frankly, a standard component built in just a process to ask that question for justification for exclusion.
So thanks, Christina. So actually, let me now turn, because we're starting to get short on time, because it's a great discussion here. I wanted to turn to talk a little bit about funding, and actually perhaps go back to your comments, Christina, about how you laid it out, that there's really two pieces here. One is funding the trials themselves, and then two is funding the science. So I wanted to ask you and also others, if we were to prioritize, especially on the science piece, are there pieces, is it about more on sort of developing methodologies, or is it that we want to understand more sort of the clinical aspects of certain types of diseases that would help us? Are there specific, I don't know if necessarily low-hanging fruit, but sort of specific areas where we really have gaps of knowledge that we feel like could really help us? So again, either on the scientific side, or it could be methodology that could really help us advance, that you would prioritize for NIH to start funding to help support the science that could help advance clinical trials?
I feel Cynthia probably is much more knowledgeable on this piece to address, but just from a quick industry perspective, I think that there are so many different areas that we need to think about in terms of funding. So I think when it comes from basic science, there are many aspects of disease that we do not understand. And when we're talking about potential inclusion of pregnant women in a general disease trial, which is not a condition of pregnancy, how much do we really know about that disease in the context of pregnancy? Do we really know if the endpoints we're using for the study of the disease itself still are the appropriate endpoints for us to be looking at for efficacy outcomes in the pregnant population? That's the answer there is neither yes or no, it's just, do we know? And then I think finally, as it relates to fetal outcomes, I think there are hundreds of areas we need to focus attention on. What actually are the appropriate outcomes we need to be looking at? No one knows the right answer here. No one knows unless it's a target-specific outcome we need to be looking at. If we're talking about off-target outcomes and developmental milestones, there's hundreds and hundreds and hundreds of papers out there, and there's frankly not a lot of consensus about what it is we're supposed to be looking at. And that gets back to Cynthia's great comment that we can't study every population for 5 years. No one can afford that. So we really need to hone in on those pieces that are absolutely critical so that we can really have much more informed outcomes as a result of these studies, so we can get to getting data that matters at the end of the day once we include the pregnant population.
Lynn, go ahead.
I guess at the risk of having my industry colleagues and friends, I'm emphasizing friends here, throw tomatoes at me. You know, I've seen in the chat and certainly in the PregLac report, the notion of a PregLac study plan. And I know that there is, you know, some, you know, concern about, well, how's that going to be implemented? How can you really talk about a plan if there's medical, legal, you know, risk involved here? I can get something off the ground. But I think what we're hearing today is probably the need for parallel discussions, right? One that talks about how do we get over this hump of, you know, how to create this path that is acceptable from a medical legal perspective, and how do we get the information that we need that's right for that particular program. And because it's going to be different for every program, the idea of creating an independent program that's early enough in development such that those things can be considered early, whether you need non-clinical, whether you can enroll patients in phase 2 or phase 3, to get PK, whether you need a post-marketing safety, what kind of post-marketing safety you need, all of that together, submitted to be discussed, may be a very important way to move this forward.
So Christina, I don't know if you guys can hear me. I think you can. I'm frozen, right?
So I would love to be able to respond. I can hear you, Marta. Yeah.
So I will, because I seem to be frozen, but yes, go ahead, Christina.
Yeah, so Lynn knows that I love her dearly, and so I would never throw tomatoes at her, but I would redirect and challenge, which we do frequently because that's just the kind of relationship we have. So I think where the comments are coming from that I've seen in the chat is because I think there is, frankly, in the external community, people don't understand what PREA is, okay? And so when you see industry immediately have their hair stand on end, it's because, frankly, the application of PREA is a one-size-fits-all approach, and it has a very big, unhealthy administrative component that's really not that helpful to anyone and is very resource intensive. And the reality is the reason why those policy initiatives were put in place for pediatrics is because pediatrics is different than pregnancy. Because in labels actually are only labeled for use in adults. And those labels did not clearly stated for 18 and older, and there were literally no products even approved for pediatrics. In pregnancy, we at least have a product where there is already an assumption that the efficacy and safety is going to work similarly in a pregnant population unless that product is contraindicated for use in pregnancy. So the situation is actually a different starting situation. And when we're talking about plans that are mandatory to be discussed at a stage of development, that is onerous and that is burdensome. And for us to put something like that in place, we have to be very thoughtful about what it is we're actually after, because not every product needs to be studied in pregnancy, nor should it be studied in pregnancy. And we frankly need to do a very long and hard look at the pregnancy space to prioritize where the need is. So there is so much that we need to do before we can even get to the point of having mandatory requirements that it makes me quite nervous from a policy standpoint to even be raising it until we build that foundation to be there where we can say, yes, in fact, there is this requirement. But I do think I want to get back to the simple things that we can do, which is it takes nothing to ask the question as to why is this population excluded? That requires nothing. It requires no mandate. And every protocol is going through multiple bodies to be looked at. So it's a very simple addition that should begin just in and of itself, begin to change the culture.
Cynthia, go ahead.
Yeah, so I wanted to add, I mean, this has been a just very interesting discussion. I think when we're thinking about low-hanging fruits, one of the things that we can consider is that there are so many prevalent chronic diseases that require pregnant women to take medications: hypertension, diabetes, depression. None of these drugs have been rigorously studied in a pregnant population, and it would be lovely for women who already need to be on these medications to have prospective cohorts. So if funders could consider funding prospective cohorts where we got information on pharmacokinetics, pharmacodynamics, because pregnancy physiology is different. And if we understood how these drugs worked, that would help to fill a data desert that we don't have. We just use them in pregnancy, concerned mainly about the fetus and really not if it's helping the mom. So we're dosing things in different ways. We have really nothing nothing concrete to tell us that this is the right way to do it, but we have these women on these medications all the time. So I think that is a potential low-hanging fruit. Allow us, fund us, send an RFA and let us do these studies on people who are taking large populations of pregnant women or pregnant individuals who are taking these medications.
And Cynthia, this actually relates to a question that was in the chat, I think yesterday, there was basically a theme about PK, PD, and the need for the foundational pre-competitive research about drug disposition during pregnancy. Can FDA, NIH, Gates, so we're talking about beyond the federal government, promote this type of research that would then enable sponsors to move more efficiently? So not just thinking about pharmaceutical companies doing this research, but what role can this be done outside, and how do we sort of nudge that kind of research much earlier in the phase? Any thoughts on that?
Yeah, I mean, I don't think it should be pharmaceutical companies alone, particularly because so many of these medications we're using off-label and we're using them frequently. I remember years ago, I tried to do a study looking at, betamethasone for fetal lung maturity and seeing whether a twin gestation or in women who are morbidly obese, should they have the same dose? We don't have that information. We've been using the drug for 40 years. It would be lovely to be able to have a study that looks at dosing of one of the most common medications that is helpful in pregnancy, but we don't have that information.
Any other comments? Lynn, did you want to make a couple of comments as we're wrapping up, perhaps?
Just one to respond, thank you.
Sure, please.
So I think the idea of applying a PREA model to pregnancy is not the right approach. It is very different. But elements of that requirement, I'm going to use that word requirement. The reason that I think as an approach, and if applied in a measured way, fit for the situation we're talking about, gets everybody on the same page. Because as you described, those stakeholders who need to learn, well, how come I'm supposed to look at justification for exclusion? There are many brilliant, well knowledgeable, the regulations of everything, even within regulatory agencies that don't know to look for that. This would provide the starting point for everybody. Look, if it's a requirement, then FDA, EMA, or at least FDA anyway, we'd have to know that that's something to look at. We create the infrastructure to look at it. And that would be, similarly applied across at least industry stakeholders. So I don't mean to say that, look, we did PREA, so PREA has to then expand to pregnant women, but something like that in terms of just understanding what the plans are early, I think is something that could be implemented in a way that wouldn't be too onerous. I'm not going to say not onerous, but too onerous.
Well, I mean, this clearly would set up for a longer discussion. I know Christina is ready to jump in, but we're basically at time. And so I wanted to use this opportunity to just basically say this has been an incredible meeting. I think there's tremendous energy and commitment among all the stakeholders that participated, that we need to do something about the current situation, and that there are things that could be done. And I think in this session that we were just in, I feel like we might have actually identified a couple of low-hanging fruit. One of them is kind of kicking the can down the road. There does seem to be a need for a sort of an independent convener to continue this conversation and bringing people to the table to have these conversations. I wanted to offer Katherine, if she wanted to make brief remarks, so I wanted to pass that on.
Yes, thank you, Marta. Just on behalf of the FDA, I really wanted to thank everyone for being part of this public discussion on protecting pregnant people through research. I appreciate all of the challenges that you've brought forth, and importantly, some of these potential solutions, especially in this last session. And I can say that, on behalf of the FDA, we're definitely going to take back everything that we've heard over the last couple of days and try to work on some of the actionable next steps in collaboration with other stakeholders. So thank you.
Well, thank you, Katherine. And so thank you to our presenters and panelists and other experts around the room for this engaging day. And I wanted to thank a few folks again for participating. I would like to thank the FDA staff who played an instrumental role. So Catherine Sewell, Christine Wen, Kavita Vashist, Susie McCune, and Daniel Mink for their and all the members of the FDA planning team. And thank you to the Duke Margolis team, Sarah Sheehan, Mira Gill, Kaylee Ropes, Luke Dursher, and Morgan Bromine for all of their efforts to put it together. Again, this was a recorded session. You will be able to see the print materials and this session on the Duke Margolis website. Thank you so much for a wonderful meeting and have a great afternoon.